and psychological safety of the patient and their families. It is highly relevant in Indian context primarily because we have the highest number of cancer incidents in the globe, 50,000 new cases every year, and close to 20% of the total cancer incident. Pediatric patients and family requires cultural and emotional safety beyond physical safety. This is a scope for improvement. And engaging child life specialists is still not much happening in India. This also improves our quality standard. Having measurable elements beyond physical and cultural safety also enhances quality and standard. So that's about it. Thank you very much.
Thank you. Have any questions? I would ask the jury to have any questions, please. Just one question is allowed. One. Any questions? No one?
Do you, good morning, doctor. Do you have any set sort of a booklet or something like for the education, patient education? Have you made some that?
I'm not very clear with the question.
Some booklet.
Some
Do you have any
booklet or
booklet?
any brochure?
So we have booklets, we have patient education cards, and we have videos.
Okay.
So videos, we give it videos, and we have Lido models, which our pediatric chemotherapy unit is in a different hospital. So we engage with them, we create these videos and share with them so that they can start engaging the patient and family from the pediatric chemotherapy unit itself. Then we call them to the department for the real orientation. This happens before the first consultation. In the first consultation, we have a process called What Matters to You, where we understand the consultant talks to the patient to understand child-specific matters. For example, I can give you an example. One of the child, the parents told that the child becomes very scared when someone other than their parent touches the child. So this information helps us in conditioning the child so that the child becomes very comfortable during the course of treatment.
Okay. Thank you.
Thank you so much.
Wonderful
Thank you very
presentation.
much.
Thank you.
No, wait.
Yes, please.
So the team primarily includes child life specialists who are actually nursing background with a psychology trained. So they are nurses with a psychology training and certification. And we have anesthesiologists and radiation oncology team members in the team. Thank you very much.
Thank you.
Thanks, Dr. Gopinath. Console guys, mics should be in front. The juries are sitting here. And we'll arrange the mics shortly. Moving on to the next presenter, Dr. Partha Pal from the Mission Hospital, Durgapur. His platform presentation number is AB494. Dr. Partha Pal, 494.
ठीक आ तो नहीं रहा हेलो ओके फिर बैक करेंगे कैसे ऐसा अरे इसको बैक कैसे करेंगे हाँ बैक ये बैक है ठीक है I'll start. No.
You start. Time starts now.
My topic is re-engineering the emergency department in peripheries for ensuring accessible, high-quality emergency care for the masses. This is a customized re-engineering in the periphery setup, and my aim is to deliver high-quality emergency care, the care which will be accessible to the masses in the periphery. My main objective is focusing on the healthcare operational strategies, technological innovations, patient safety, and awareness. So mainly, the main objective is infrastructural development and CAP activation, knowledge, attitude, and practice activation. Now, coming to the case scenario, why this came to my background? It was because working in a periphery hospital, sitting in an upgraded PAC, I got a child, a small child, coming with convulsions from a small hospital to the upgraded PAC. The child has got only injection diazepam because the peripheral access could not be done. And when it came to me in the upgraded PAC also, I failed to do the peripheral access. I gave the parenteral diazepam and the patient convulsion stopped, but there was a respiratory arrest. But my knowledge of my training I got to do the resuscitation and could save the child. But on the same case scenario, on the other, sitting in a corporate hospital, when a patient comes with an accident from the Panagar with crumbled limbs, and when I tried to resuscitate, the patient was resuscitated, but the patient collapsed because of the faulty transport which happened, and there was an embolism and the patient died. So based on this background, I thought this periphery should be taking the quality outside, taking quality to the base level, to the peripheries, the mind, this thought came. And now coming to the literature review, as per the National Health Policy 2017 report, the policy envisages creation of an unified emergency response system linked to a dedicated universal access number. Now, as per the project report submitted to the Niti Aayog Government of India, conducted by Department of Emergency Medicine, All India Institute of Medical Science, as per one estimate, more than 50% of the death and 40% of the total burden of disease in the low middle income countries could be averted with the pre-hospital and emergency care. Emergency care system in our country suffers from fragmentation of services from pre-hospital care to the facility-based care in the government as well as in the private area. So
You have 1 minute left. You have 1 minute left.
So this is just an innovative idea that what can be done, how the infrastructural setup can be made in a periphery hospital. It consists of a Thomas plane, consists of a cervical collar, consists of a defibrillator, and making this basic things, we found that the approximate total cost is only rupees 1 lakh. And by the next process that we have to do the knowledge, attitude, and activation, we are in the process of doing it. And in this process, we have done around 39 different hospitals of the peripheries in the West Bengal have been considered. Participation from 39 different hospitals, and there we have done this knowledge, attitude, and activation of the basic life support of the basic support system. And coming to the data analysis, we did a pre-hospital and a post-hospital. We did an analysis pre-training and the post-training, and we found that there was a positive shift in the knowledge, attitude, and practices. And if we could induce this knowledge and practices to the periphery doctors, nurses, and technicians, I think the system can improve. And the last slide, the recommendations, is to the visionary concept of developing a robust, customized, integrated emergency service system, which can comprehensively address all emergencies in the need of the hour in the Indian case scenario. And we are doing this program as Mission Connect. I, being the medical director of Mission Hospital, is on this process along with my team of other doctors, Dr. Arithro of emergency, and other quality persons. Thank you all.
Excellent. Any questions, please? Emergency management is by far one of the most important things for any hospital. Anybody have any questions? Yes. Yes, ma'am.
Thank you for your detailed presentation. We would like to know, you mentioned that the cost was around 1 lakh. So if you can just elaborate a little, was this the cost of setup or a recurring cost for the consumables?
I couldn't, it's not audible actually. Yeah.
So you mentioned about the cost, that it
Yes.
was 1 lakh. So if you
Yes.
can just elaborate a little about it.
Yes. So what we did is that the basic things, for example, patient coming with a road traffic accident needs a cervical collar. So that basic infrastructure, basic infrastructure development, which include the basic appliances, like.
So it's a cost of
And the
consumables.
cost of estimation for one set is coming 1 lakh rupees, around 1 lakh. So if at least we keep in small hospitals a set of 3 or 4, it will be coming around 3 to 4 lakhs.
But then these are consumables. These are consumables, so you'll have to put it as a recurring cost,
We have to,
as a recurring cost, isn't it?
as a recurring cost. Yeah, there is a need of recurring cost, but I think this is the minimal resources setup we can have it.
Okay. Thank you.
I think it's
And
okay.
government also to.
So we go to the next presentation, please. Thank you, Dr. Pal. Thank you so
Dr.
much.
Thank you, Dr. Partha. We move on to the third presenter, Dr. Shanmuga Priya, RA, from Kaveri Hospital, Vadapalani. The paper platform presentation number is AB 503. Just one instruction is that only 5 minutes will be allotted for the presentation. So you'll have to complete your presentation in 5 minutes. No more extension will be given. And then 2 minutes is allotted for the Q&A. Okay.
Good morning,
Yes,
all.
start.
My name is Dr. Shanmuga Priya. My number is AB 503. My topic is enhancing the quality of blood transfusion services using the AI. Blood transfusions are life-saving procedures, and precise documentation is essential to ensure patients receive appropriate blood products and mitigate adverse reaction. The form we see on the slide is the blood component requisition form, also called as the cross-match request form or the reservation form. All the details given here carries the immunohematological significance. So any inaccurate or incomplete data in this pose significant risk to patient safety. So in order to overcome this, we undertook a study in our hospital, and it is called as a study on effectiveness of just-in-time training to reduce blood transfusion request errors among the healthcare workers. So what we did was, retrospectively, we audited 300 blood component request form, and then we intervened using a JITT video module. In this just-in-time training video module, we explained to the staffs how to fill the form, how to prevent the errors. And then we did a prospective audit of 300 blood component request form. The results were there was a complete and current responses increased from 69% to 95%. Incomplete responses reduced from 7 to 2%. Incorrect forms, they reduced from 23 to 2%. But this study had limitations. So in order to overcome the limitation, we undertook another study which integrated AI along with JITT. So the limitations of the previous study became the problem statement for this study. There was a difficulty in implementing JITT as a regular training module. The video module which we shared, we had to keep on emphasizing the staffs to go through it for continuous training. And drawback in developing customized training. The JITT module was not customized for staff nurse, DMOs, or the consultant separately. It was a single video module. And time and manpower expenditure for continuous monitoring and evaluation of this video module and the outcome was difficult. And there was an absence of user-friendly interface to enhance the convenience and ease of use while maintaining patient confidentiality and organizational data integrity. So the PDCA cycle became very tedious. So this study aims to enhance the efficacy of combining artificial algorithm with just-in-time training to prevent blood transfusion request error. And it also aimed to create an easily accessible and implementable JITT module for training and retraining. This is a quasi-experimental research design, and the request forms were digitally collected for 3 months. This is the hospital management system cross-match request form. The staffs are expected to log into this using the username and their employee ID. This is also interfaced with the HR HMS app, from which we can draw the data of the staffs, and also with the blood bank training, blood bank software. The details were uploaded into the Python platform, and comprehensive analysis was done for data completeness, accuracy, to identify pattern and correlations. The AI algorithms used were random forest, logics regression, and gradient boosting. Special attention was given to feature extraction with focus on variable of job specialty. So among the AI algorithms, random forest had an highest accuracy rate of 82%, and there was minimal false positive rate. This was followed by logistic regression and gradient boosting. So based on this, the job specialty can be considered for tailoring the JITT program, and then that would be reflected in the HR app whenever there is a wrong entry in the HMS platform. So by enforcing strict validation rules, we are able to mitigate the risk of errors and at source itself. And it increases the accuracy and reliability of the data, so it helps in improved clinical decision making. So the random forest algorithm helps in real-time notification of errors. It enhances the accuracy of the standards used, and it also helps to customize the JIT training program based on the experience and knowledge of the staffs. So let's embrace JITT with AI algorithm to make healthcare services efficient, to reduce errors and wastage, effective use of manpower to deliver quality and safe services, economical in terms of time, equitable in and knowledge sharing. Thank you.
Thank you, Dr. Shamuga. I would like to have some questions from the audience.
Yeah.
Judy, please.
Yeah, there's one
Anything?
question. So it's an interesting kind of study. The first question I want to ask is, what you've done this customized JITT. Is it mandatory for every person after filling the form that after the form is sent off, they have to go through the training? How do you go about it? Because what is the provision in place that the person definitely watches the customized video?
Okay, sir. So there is the cross-match requisition module in the HMS.
Yeah.
If there is a wrong entry, then the AI detects it and it sends the JITT video module to the concerned staff HR.
Correct. How do you check whether the person has actually watched it after the thing? What is the proof that the person has actually watched the video?
So actually the video, the attendance, it will.
Correct. So first you'll have to make sure that every person who has made an error has actually watched the video or not. You need some proof for that. The next question is, what you showed that initial JITT, there was an improvement. Do you have a proof that it has actually worked? And there is, because you do not have a post implementation of this. It's good about the AI implementation. You've created a new software which creates a customized for depending on the 4 categories of the healthcare workers. You've created a module. But the next step would be, you haven't showed us the data about what is the change in the errors in the forms after the implementation of this AI-based.
Video for that, but
The data for that one as to what was the post-implementation, what is the present
Do
compliance?
you have a success rate? I mean, he's asking about how much percentage of people have.
I've shown that in the video, ma'am,
Okay.
in the PPT.
I think
That's with the forms. You showed with the forms. So after the AI implementation, what is the, do you have the data for that?
At this point, we have implemented only the accuracy rate.
So
of
there's an
the-
implementation
Yes,
study of an AI-based
algorithm.
just-in-time.
Yes.
Okay, thank you.
Thank you.
I think that's all. Next presentation.
Thank you. Thank you, Dr. Priya. This was the third, this is basically a clinical category we are part of, and this would be the last of it for the 4th presentation by Dr. Yamuna Devi Ramanathan from Apollo Hospital. AB 550, platform presentation number AB 550. Madam, echo is better. Yeah, thank you.
Good morning, all. My topic for the clinical category is Care Coach, a new approach to integrate care from bed to bench. Our problem statement was globally, surgical site infection is the most frequent type of healthcare-associated infection on admission. And in the year 2022, 69% of our SSI were post-cardiac surgery patients, and 56% of the overall burden were due to deep-seated SSI, despite implementation of the multimodal strategies from CDC and WHO. And among all multifactorial causes of SSI, the reason was a delayed presentation of patient contributing the most important factor for deep-seated SSI. And it is an unpleasant experience for the patient, which increases the care burden on family and community, and thereby increases cost for the patient and providers. Hence, we hypothesize that enhanced monitoring of patients in the post-discharge period would provide valuable insights in early detection of infection and thereby prevent deep-seated SSI. Our team decided to address this problem statement following a detailed root cause analysis using template of 5 whys and process flowchart templates. Our main aim was to strengthen the SSI surveillance for post-cardiac surgery patients and thereby enhance the patient outcomes by providing personalized guidance and support, bridge the gap by enhanced communication and collaboration between the healthcare team members, and to optimize the healthcare resource utilization. Our overall objective was to increase the phone call surveillance by 350 every month, to increase patient and family-related follow-up factors by 80%, enhance communication between team members by 100%, to reduce unnecessary hospital visit by the patient's family by 60%, to reduce the cost spent by patient and their family by 60%. Our data collection was done according to the NHSN criteria 2023 for SSI. We included all the patients who underwent cardiac surgery in Apollo Hospital. Our sampling period was between March 23 to February 24. It was a purposive sampling technique. Exclusion criteria: only people who were unable to communicate independently over phone were excluded. We followed the Plan, Do, Study Act, where we planned accordingly, like data collection, define our goals, timeline, decided our task forces, which included surgeon, cardiologist, infectious disease, nursing, and infection control population, process mapping, gap analysis, study solution-based. Results were shared with the leadership team, and we maintained and monitored the improvement. So we defined the PDSA cycle, which was, we listed the entire task, person who was responsible, when it should be done, and where it should be done. The task assigned was totally a patient-centric approach, where the care coach was a liaising person between all the task forces which was given, right from the post-discharge wound status in the ward and the ICU. At the time of discharge, the wound status education was given to the patient by the clinical team, by the nursing team. In the same wound status update was given, and the discharge summary, how to follow up with the wound. The care coach could make a video call follow-up at 10, 20, 30, 60, and 90 days, and advice was given to the patient based on a scoring matrix. It's a validated scoring matrix which was created after discussion with the cardiothoracic surgeon team, which included 7 platforms to follow up with the patient, and the communication happened based on the scoring matrix. If it's 0 to 5, the advice was given by care coach over the phone, where there was unnecessary a visit to the patient, a visit to the hospital was avoided. 6 to 15, communication with the clinical team. If required, patient was asked to come to the Apollo OPD with already done pre-registration and pre-appointment, or through telemedicine with a fixed appointment. If it's 16 to 26, the care coach can eventually call the patient directly to come and get admitted in our hospital or get admitted in nearby hospital, through which we contact the patient. This is our overall cardiac patient journey in our hospital, right from emergency or OPD admission to ICU, ward, post-operative status, communication, and yes, a beneficial patient outcome with decreased deep-seated SSI and unnecessary hospital visit. This is our overall cardiac surgery rate, where we began the project in the month of March. Team goal setting score matrix implementation period was in the month of June, when there was again upsurge of SSI. We could see one more upsurge in the month of August, when there was an increased phone call pickup and advice for the patient was identified. And over a period of time, we could see a reduction in overall surgical site infection rate and a zero surgical infection rate in the last 1 or 2 months. These are our project outcomes. In the process measure 1, the phone call follow-up increased to around 350. The process measure 2 related to patient-related factors like the glycemic control, wearing a chest band, glycemic control, bathing for the patient appropriately, spirometry. These were the other factors which can contribute to the SSI was done, which was around 100%. Process measure inter and intra communication team definitely improved after the QI project, which is around 100%. Outcome measures 1 and 2, unnecessary hospital visit was reduced by 90% and cost saving for the patient increased by 90%. These were the tools and protocols by which we used to identify the issue and sort it. My conclusive remarks: reduction in deep-seated SSI is possible by targeted or care-oriented approach to prioritized group. Personalized guidance to patient and family on timely basis builds trust and bond patient healthcare organization. Thank you.
Thank you for the nice presentation. Judy, any question?
Yeah, it was a nice presentation.
Thank you, ma'am.
Yeah, what are the challenges you usually see when you have to communicate to the patients on a phone call follow-up? Can you just tell us?
Sure, ma'am. The problem or the challenges which we usually face is the language communication. And the second challenges before this QI project, which we used to face, was what to ask the patient and how to interpret their data if they come up with certain complaints. But the score matrix has definitely helped us to identify these challenges and put a scoring for each of the problems identified. The third challenge, which we still have which we couldn't overcome, is the wrong phone number registration, where people who come from outside Chennai or Tamil Nadu, travel from North India, they register their phone number with a local number. So following up of those patients really becomes a challenge for us.
So I had one question. You
Yes,
showed that the graph of your SSI rates. So from what we understand, the study included 2 interventions. Number 1, comprehensive kind of interventions, which led to a decrease in the SSI.
Yes.
Second is an early pickup rate and reduce the number of unnecessary visits to the hospital. Now, in the other spike that you had mentioned, that the SSI that
In
is
the month of August. Yes.
So that doesn't justify, because it's only about a pickup for SSI. SSI would still have happened. So the rates do not justify the pickup by the phone. It's an early pickup for an SSI. So that data you will have to, I'm not sure. Because
Yeah, so that data in the month of August, we had 5 surgical site infection, but luckily all the 5 were superficial site infections.
Okay.
So our main aim of the study was to prevent deep-seated SSI because of delayed presentation to organization. But after looking into the QI project, we saw that not only the deep-seated infections became 0, but we were able to come down on the superficial site infection rate also.
So those are the rates for the deep-seated infections?
Yes, yes, yes.
So the superficial infections.
So this, the graph which I projected includes all types of surgical site infection related to post-cardiac surgery. In the month of August, the pickup rate of even superficial site infection increased, and over a period of time after August, the entire surgical site infection rate
So
decreased.
do you mean to say earlier they were
Yes.
being missed?
Yes,
Superficial
they were increased in rate.
I have a small question,
Yes,
ma'am.
ma'am.
Just let me understand that when you are doing a study like this, have you ever considered the cost? I mean, what was the scenario before that? How many repeat visits were, could you control? Like suppose you have done 100 surgeries a month. How many patients revisited the hospital? And what was,
How many?
suppose you have done 100 surgeries.
Okay.
Okay. How many of them revisited for infection, particularly SSI? And what was the cost involved? Do you have any study on that?
Yeah, ma'am. Pre-interventions, our phone call follow-up was only 30 and 90. And the purpose of interlinking the healthcare team was that there was a disconnect. How many patients actually visited the OPD and how many we were picking up was totally not integrated. But after we started doing this project, we were 100% sure that how many actually came into the organization and how many visited the doctor. So that improved our inter and intra communication among the healthcare members.
Okay, thank you. I think we should go for the next presentation.
Thank you.
Thank you, Dr. Yamuna Devi. That were the 4 presentations from the clinical section. Now we move on to the nursing section. I'll call upon Ms. Munira Anifa from the Pantai Medical Center. Her presentation number is AB317. AB317. Again, the same rules, 5 minutes for presentation, 2 minutes for Q&A.
Good morning, ladies and gentlemen. My name is actually Kalai Selvi Kumarisan. My colleague who's been with the poster presentation was Munira. So I'll be presenting the talk today. Okay. Okay, my study today is about perception of sharp safety injury practices in the operating theatre for the operating theatre nurses. So I'll start with the introduction. The reason for us to embark on this study is there was an increase of sharp injury cases reported in our operating theatre comparison to the hospital-wide incidents. So clinical sharp injury is defined as a penetrating stab wound caused by any sharp object such as a needle that resulted in blood or body fluid exposure on an intact skin or mucous membrane. So we had done some statistics review. The CDC reported 385,000 of sharp injury occurring annually among healthcare personnel. And similarly, we also noted that operating theatre was highest incidence reported. So as a known fact, the potential risk of bloodborne viruses includes this listed hepatitis B, hepatitis C, and HIV. This was also a concern why we embarked on this project. Okay, our objective of study was to understand does a stressful condition elevate the risk of sharp injury? Does cultivating a strong safety culture helps to reduce the health risk? And finally, understanding does the nurse's perception helps in putting our intervention for a better outcome? So our study was designed using a simple questionnaire, which was distributed to our operating theatre nurses. Following their verbal consent, we received a 60% response rate. So this study was focusing on the safety practices along the tissue retraction, establishing of neutral zone, surgical blade removal, needle recapping technique, as well as staff perception on safety culture. As a result, we categorize it under low and moderate risk. Low risk is since the staff are not more prone to get injuries. So 90% of them agreed that establishing neutral zone was crucial. The moderate risk is 30% of them feels that manually removing surgical blade or providing tissue retraction can be done safely. And 50% feel that practice using recapping can be safely done. And 53% of them feel that anxiousness during surgery due to fear of injury. And also the same percentage felt that having posters at workplace will be very helpful as a reminder. Following this feedback from the staff, we did a deep dive analysis to understand what was the potential root causes using a fishbone or Ishikawa diagram. And these are the potential causes we have identified. We identified 5 potential causes. Number 1 is lack of awareness or knowledge. So to address this gap, we started with a simulation-based learning where the staff are given scenario to understand their competency level and also their knowledge on safety protocol. Secondly, we come up with a acronym called Keep It Safe and Sound KISS. So posters and computer screensavers was created to as a reminder for them to increase the awareness on sharp safety protocols. And daily roll calls place was also given to the staff at the beginning of the shift to remind of the steps on the case. Okay, next is lack of assessment. So we identified that there were some junior nurses in our team. So we come out with a checklist to guide them on how to do hand-free passing technique as well as a neutral zone establishment. Thirdly, on lack of cooperation among the doctors. So we also identified this problem. So we work with the doctors, we bring up these issues with the doctors working group to get their cooperation, to remind them about the safety protocol by alerting the team when passing over sharps items, as well as safely receiving and placing the sharps into the neutral zone. And then fourthly, lack of communication. To address this problem, we work with we come out with a mentorship program where it helps our junior nurses to reduce their fear during assisting in the surgeries. Finally, there was underutilization of safety devices. To address these gaps, we introduced some safety devices such as suture box, also sharp removal. So there were some other things, but we started with this two first. So in conclusion, I would like to conclude saying like taking a holistic approach actually alleviated the physical safety and psychological stress felt by our nurses. And mental mentorship partnering along with nurses empowerment has boosted the staff confidence in voicing out any non-safe practices during surgery, and implementing multifactorial interventions increase the awareness. And also, we also recognize soliciting staff feedback was crucial in our interventions. So at the end of the project, we managed to reduce 30% reduction in the sharp injury in the operating theatre. And also we understand that continuous feedback is crucial in maintaining or sustaining our effort. Thank you for your kind attention.
Excellent, excellent.
No, it's okay. It was a nice presentation, small and crisp, within time. Still 8 seconds left. So, any questions from the?
Yeah. Madam, you have shown that there is a 30% improvement in the performances, right? Now, do you have any authenticated data? You have shown somewhere around 50 is the number of samples that you had collected.
Yeah, 50 is from the nurses, from the samples that we collect from the staff to assess their knowledge on the shock safety protocols in OT. Can you hear?
So just, we want to understand what was the rate of injuries before your intervention? You've shown 30% improvement. What was?
Before that was 50%.
It was
Previously,
50%.
it was 50.
Okay.
Half of the injury from the operating theatre is coming from, or the hospital-wide incident is coming from OT.
So over a period of how many months did you get? So the second phase of this, after your implementation, what are the total number of the sharps injuries?
It's a period of 6 months.
So what was the number of sharps injuries during that period?
Sorry, sir, I didn't get.
What was the number of sharps injuries during the second phase after implementation of this?
Second phase, we reduced by 30%. Previously.
What are the numbers?
Number of cases, is it?
Number of injuries, number of realistic injuries.
Number of injuries.
Number of injuries.
Yes.
Number of injuries.
You've just shown us
by obsolete number, we have 3 cases. Initially, it's about 5 cases.
So for 5, you reduced it to 3. Okay, all right. So that's what you're saying, 50.
That's only in OT, operating theatre. It's not because our study is only focused in OT.
I think it's okay. So we go for the next. Thank you, ma'am. Thank you so much.
Thank you.
We move on to the 6th presentation. May I call upon the presenter, Ms. Janita John Wagela. She's from Zydus Hospital, Ahmedabad. The platform presentation number is AB352. I repeat, AB352.
Namaste. My presentation is regarding the reduction of collapse rate in pediatric post-surgical ICU by implementing multimodal strategies of infection prevention and control as a part of patient safety. Before the study, I want to share some amazing facts about the microbes. The microbes are our seniors because they come into the planet about the 4,000 million years ago. The microbes are very familiar to this planet. So they are the biological computers. So there is a constant battle between the microbes and the human beings. So we cannot completely kill them, but we can control them by following the infection control practices. But when we people meet about the infection control practices meeting, at that time, the scenario is like this. On the other era, when the microbes make a strategy to attack the human body, the scenario is like this. So we can call the microorganisms are the biological computers and they are the very intelligent. So microbes have some intelligences like decision making, communication, city making, etc. So my aim of this study is to identify the 50% reduction of collapse rate in pediatric post-surgical cardiac ICU within the 6 months monthly, implementing multimodal strategies of infection prevention control. As we all know that HAIs are the most common burden on the healthcare delivery system, and collapse is one of the most common HAI. So as per the CDC is providing the guideline and tools to healthcare community to help end the collapses because these infections are the preventable. So this study is conducted in the two phase. In first phase, we have done the retrospective study for the 6 month, for the period of 3 years. So we collect the baseline CLABSI data from the year 2020, 21 and 22 for the average CLABSI rate. In the second phase, we implement the multimodal strategies and we compare the data for the 6 month of period, retrospective data. So our baseline CLABSI rate was 6.34. We want to 50% reduction by the implementation of multimodal strategy. So we implemented this multimodal strategy. So first we re-emphasize on the central line bundle care. Specifically, we emphasize on the scrub the hub protocol by the 70% alcohol by the 10 time twisting movement. We also focus on the hand hygiene compliance and also the hub putting area. In secondary, to improve the hand hygiene compliance, we set a central announcement system every 2 hourly for the every area to say that please do hand hygiene, clean hands counts. We also started giving the feedback to the staff for the hand hygiene compliance rate individually, ICU wise and category wise. So individual can improve their hand hygiene. We also start the motivation for the staff, so we can give them star of the month, hand hygiene champion, etc. because the motivation is the key factor. We also start the enhanced interactive incorporated training, audiovisual training in small groups, 6 to 7 people instead of the classroom training. So people can more engage with the training. In that, we include the aspects like fundamental of asepsis, hand hygiene, safe injection practice, environmental cleaning. Also, we improve the decontamination of environmental. We frequent environmental deep cleaning. For that, we make a calendar for the deep cleaning along with the routine cleaning. So after this multimodal strategy, our outcome measures are like this. So our CLABSI rate is gradually decreasing trend. Also, we document our hand hygiene compliance before intervention and after intervention, hand hygiene compliance rate is gradually increasing. So we have done the bundle care audits. For that, we have also improved our bundle care compliance, specifically scrub the hub protocol, which is before intervention 50% and after intervention it was 69.8%. So the learning outcome is in initial phase, we also faced some behavioral issues, attitude issues, resistant to change. But as Swami Vivekananda said, that every new idea is a joke, but gradually we can overcome by effective communication, team building spirit, it was accepted. So our findings suggest that clinically relevant reduction of post-surgical CLABSI was reduced with a multidisciplinary and multimodal intervention improvement, including aspect of behavioral change in a practical manner and key principle of good implementation practice. In this sense, our strategies is more in depth than some protocols of. Okay.
Thank you. It was a nice presentation. CLABSI is always a concern in the critical care setup in hospitals and leads to a lot of the cost involvement in critical care. So, any question from the team? So what sort of this is? Oh, she'll ask. Yeah, please.
So this is a multinodal study, but can you tell us how did you measure the learning outcomes of the staff you have trained?
In training, we have every week 4 days training classroom. The first 15 minutes we spend for the pre-test. After that, audio-visual presentation. And after we have done the post-test. And we evaluated the pre and post-test.
One of the challenges we face is about the hand hygiene compliance. And when you mentioned the scrub the hub, was it everything was a direct observer-based compliance which you calculated? How was it done? Because
yes, we have done the direct observation and we have set the central announcement system. So at that time, the in charge or the link nurse, which is observed at that time, every person, every healthcare worker do the hand hygiene, and we observe that directly and documented in the WHO hand hygiene observation form.
And the hub being cleaned every time was again observed every time. How did you get that percentage compliance to increase from? Meaning this was a retrospective. Did you Did you ask a question whether the hub was
No,
clean?
we
or was it directly
observed the 7 step of hand hygiene as per the 5 moment of hand hygiene.
You were talking about the scrub the hub.
Scrub the hub. Yes, for that we have done the audit. We focus on 3 areas. First, the hand hygiene, and then the scrub, the technique for the 70% alcohol, and the hub putting, because sometimes the healthcare workers put the hub on the locker or on the pocket. So we do the audit on those 3 points, and we make a data by the audit.
So this audit, everything was the direct observer audit by the IC.
Direct observation
By
by
the IC.
the IC team.
How many ICNs do you have?
4 ICNs.
Oh, thank you.
Thank you.
Thanks, Ms. Janita. I call upon the next presenter, Ms. Sylvia Vasewala. She's from UN Mehta Institute of Cardiology and Research Center. Her platform presentation number is AB637. I repeat, AB637.
Good morning, everyone. Thank you, Kaho, for this incredible opportunity. It's my immense pleasure to present my study, which was on enhancing patient satisfaction through the implementation of the aided communication framework. I forward my gratitude to UN Mehta Institute of Cardiology and Research Center and want to thank my team for their unwavering support. Here I would like to say something about my institute. It is a 1,251 bedded cardiac hospital and is one of the biggest single super specialty cardiac teaching hospital in the country, also in the world. This is the vision and mission. So, to present initiative of this study effectively, we have used aided tool for its implementation. As we know, communication is a major factor for any organization. The priority concern is patient satisfaction, and it shall be improved through effective communication. So firstly, start with a brief overview of problem statement. To our institute identify need for clear communication guideline for newly recruited nursing, and also involvement and observation that has been highlighted by patient right and education team due to significant communication variance. To address this as a solution, our institute introduced the aided communication framework. Aided is an evidence-based communication practice that enables to provide more effective care. Aided is a 5 key communication behavior that create positive care interaction. Aided is an simple acronym: A for acknowledge, I for introduce, E for duration, E for explanation, and T for thank you. Aided is a scripted method that provides a strategic solution to standardize and improve the quality of communication between nursing staff and patients. Our aims and objective of the study was to establish a uniform communication, to enhance patient experience, to implement a system for regular monitoring and evaluation of communication practices, and also to understand, to strengthen patient-nurse relationship. So while implementing the aided tool, we encounter with these challenges for nursing staff, effective adoption of aided principle. So address this, we provided comprehensive training to ensure better adoption and understanding. The next challenge faced was language barrier and for the need of multilingual support. To tackle this, we explain and translate script into Gujarati, English, and Hindi. For continuous monitoring and evaluation of communication practice, we conducted regular observations by departmental senior nursing staff. And for ensuring consistent adherence to the aided protocol, we conducted follow-up audits. As a result of our study, we measure degree of improvement in services can be quantified through active participation from nursing staff, patient right education team, departmental senior nursing staff, and patients. Also, we ensure accessibility for diverse patient population with multilingual support. Initially, we started as a pilot project implementation in non-critical wards. After expanded it hospital-wide implementation following successful pilot phase. This is the script which we used for aided tool to improve nurse patient satisfaction in our study. It's available in 3 languages. So nurses were trained to use it during patient interaction. In using aided tool, we measure patient satisfaction score. We have seen remarkable patient satisfaction score, including in acknowledged phase, an average 95%, in introduced phase, an average 91%, in duration 92%, in explanation phase, an average 94%, and thanks, an average 92%. So, an overall average satisfaction score of 93% for nursing interaction with patient. So impact and outcome of this study is improve patient experience by high satisfaction percentage. So it helps us to enhance trust and rapport between patients and nursing staff. And this is aided tool with questionnaire which we used in our study. To sustain the aided communication frameworks, ensure lasting impact by standardized communication practice through ongoing training and monitoring, also audits and feedback mechanism, maintain these standards over time. Additionally, as we do this study, the structured approach of the aided frameworks is replicable in other healthcare settings. In conclusion, I want to summarize the key point of my study. As we are using this, its positive impact on patient satisfaction and average score 93%, and also foster strong relationship between staff nurse and patients. Thank you.
Thank you.
You had mentioned the compliance more than 90% after the implementation of the audit for your PRE. What was the rates before this? What is the
Pardon?
compliance rate?
Can you repeat?
You showed that slide, which was the impact and outcomes, everything 90% and above. What were the rates before this implementation of this protocol? What was the compliance rate and the satisfaction rates which you mentioned, that table that you showed? Do you have the data before because throughout these 2 years, you are 90% compliant?
Yes, sir. We are collecting this methodology of this study is simple random sampling.
No, I understand that, but before implementation of this aided kind of thing.
I can't audible.
I'm saying, I'm just explaining. He's asking before. Iske aage kya tha? What was it before? The compliance rate. Your sample size must be something.
Okay, 693 sample size.
Before, what was the rates before, he's asking? Now it is 92%.
Sir, this is the prospective observation study, and we plan to implement this to maintain this continuously.
Why did you think to do this study? What was the objective?
Because in our hospital, it is as I mentioned, it is a 1,251 bedded, and we experience heavy patient load. So to establish a clear communications between patient and nursing, we implement this scale.
Thank you.
Okay, thank you.
We move on to the 8th presenter, Mrs. B.G. Jason. She's from Ruby General Hospital Private Limited. The platform presentation number is AB 647. 647.
Good morning to all. Myself, Sister B.G. Jason, DNS from Ruby General Hospital. My topic for presentation is crisis handling with silence. All types of clinical crisis to the patient get addressed in structured manner with predefined steps by efficient workforce to enhance complication-free outcome and least suffering. Let me start my presentation with a quote from Mrs. Gillian Michael, famous American author and businesswoman. It's not about perfect, it's about effort. And when you implement that effort into your profession, changes occurs. Yes, we have experienced the same in our Ruby General Hospital. As we know, the rapid response team in the hospital is to intervene swiftly and effectively when patients show signs of deteriorating health, thereby preventing progression of clinical deterioration and improving patient outcome. The aim of this project was to ensure early detection of warning signs of patient deterioration and prevention of cardiac arrest. And our objectives were early detection, timely intervention, comprehensive management, enhanced communication and collaboration, finally, education and training. Though we had RRT in the year 2021, but we had no preset criteria for the same, and we noticed a rising trend of code blue too. So we conducted a quality improvement plan by prospective and retrospective studies by using PDCA model to solve the problems and implement solutions. First, we planned B1 progress, looking at the root causes of issues and setting goals to overcome these obstacles. Next, we decided our course of action. That was training and empowering the staff nurse, at the same time, introduction of MUSE. The study period was for 3 years, and the population was all patients admitted in general wards. We have fishbone diagram to identify all possible causes related to rising trend of cold blue in general wards. Among the causes, the major contributing factors were no dedicated RRT team members, lack of competent staff due to premature transit for delivery in bedside care, and pandemic situations. To overcome all these causes, first we introduced a specific RRT team, including in-charge, shift in-charge, nursing supervisor. And we started RRT assessment checklist with specific clinical parameters and close monitoring of critical alert values. We introduced preceptorship for new journey for the senior handholding and assessed the staff competency and conducted monthly RRT and code blue analysis. As part of process upgradation, we have introduced MUSE along with escalation matrix to provide a structured protocol for escalating patient care and conducted daily training on RRT and weekly mock drill. Even we are conducting employee recognition to feel them that the staff that they are valued, respected, and motivated to perform at their best. This is the statistical analysis of pre-data that was from January 21 to December 21, and statistical analysis of pilot study data that is January 20 to December 22, and finally statistical analysis of outcome data. At the research, we have noticed the number of RRT has been increased 153 to 153 in the year of 2021 to 248 in the year of 2023. And the code blue has been decreased from the number of 25 in 2021 to 11 in the year of 2023. Regarding staff addition and training, the attrition in the year of 2021, it was 5.31. And it was decreased to 2.43 in the year of 2023. And regarding training, total RRT training happened in CNE. Initially, it was 21 in the year of 21, and now it has become 48 in the year of 23. And total RRT training in unit teaching, previously it was 256, and now it has become 429. So, to conclude, the approaches to address an issue in a structured manner with predefined process and efficient staff would make the intervention efficacious, effective, economical, and equitable. Thank you.
Thank you. Nice presentation. One question, please. One question allowed.
Yeah, so you have shown that the code blue has reduced because of the effective implementation of RRT. So, you have also put up that training on spot for RRT. How do you do that, and how did it reduce the code blue?
Sir, after each RRT, If there is any process variation, we used to conduct spot training, and it is compulsory to do spot correction at the time of RRT. We made it as a process, and we are having weekly mock drill and daily training also on RRT.
Yeah, so but when you say spot training, is there any emphasis you're giving on, special emphasis? Because training happens for RRT very regularly as a part of continuous training program. So on spot RRT training, what does it mean like?
Ma'am, on spot RRT is giving the chance to give spot correction to the staff, because we already mentioned that we are having a high rate of attrition in the initial period, because the staff who are newly joined, they were not trained in RRT. So when we will go for the rounds, we can do the spot correction and we can keep them trained.
Do you train the RRT guys or all the person who is doing the? You train the RRT people on spot.
Sir, in case of RRT, the nursing supervisors are also part of the team. If any RRT is there, as part of the supervisor team, we have to go there. And if there is any correction, we have to do that on the spot. And if they are doing good, we used to encourage them.
The RRT teams are all senior people, no? All the shift in charges and all.
Pardon, sir?
Your RRT team are all shift in charges.
Nursing supervisors.
Supervisors.
Yes, sir. In our RRT team, in charge is there, nursing supervisor is there, and on duty, ARMA is there.
Thank you.
Thank you. Thank you very much.
With that, we conclude the nursing category and we move on to general and support services. The next speaker would be Mr. Anupam Mukherjee. Mr. Anupam Mukherjee is from GPT Healthcare. And his platform presentation number is AB254. I repeat, AB254.
Namaskar, I am Anupam Mukherjee from ILS Hospitals, GPT Healthcare Limited. So, while analyzing our OPD satisfaction data, we found OPD waiting time is one of the most common problem on that. So I'm starting with a study reference in National Library of Medicine site published on US-based publication, effect of waiting time on patient satisfaction in outpatient and empirical investigations by Hu Zhang and his team. So the study shows a 1 minute increase in reasonable waiting time, patient satisfaction decreases by 0.16 points. On preview of that, we initiated this study as our problem is much more similar with that study. We have finalized our aim of the study, that is enhancing patient satisfaction by reducing OPD waiting time. We have followed DMAC for methodology. We have defined our aim and objective to the reducing waiting time, measured our waiting time and its crucial touch points, analyzed the data from every global aspects and narrowed it down further for exact problem statement, and also initiated CAPA for the improvement with controlling measures. In next few slides, we will give you a highlight on that. This is a baseline primary project and the timeline is 5 months. You can see the baseline of this study, the data which we have taken as a baseline is month 1, the average test was 55 minutes. So when we break down this data, we found much more interesting thing, that we are scattering 57% of the patients within the 45 minutes of our OPD waiting time, but we are not able to cater within the 45 minutes stat, 43% of cases, and the average waiting time, which is exceeding our TAT, is 1 hour and 44 minutes. That was pretty alarming. So we have done a 5-way process, starting with we have found 4 major points: doctor coming late to OPD, doctors doing other activities between the OPD, and we have found consultant-specific consultation time is greater than our slot time, and patient coming late. That is also a problem which later we have defined. So on Y1 end up with the Y3, doctor slot time is not met as per outside chamber. Scheduling OPD slots without discussing with clinicians and their preferences about IPD round time. Point number two ends with no schedule for procedure in between OPD, no schedule for IPD rounds in between OPD, consultation, specific consultation time greater than the slot time ends with doctor's consultation time was not monitored, slots were not put as per the average consultation time, and the last one was found, that is our technical glitch in our system. The patient who is coming late, the CAT is calculating from the slot time which is given previously. On further breakdown of the data, we have started talking with our consultants, and we have started and recommended few changes in our slot time. Like in the first matrix, you can show Dr. KSP slot time was 4 to 6 p.m., but his usual IPD round time was 4 to 5. So we have changed our slot time to 5 to 7, and we have started informing patient as per the slot time so that we can save their 1 hour time. And in the next part, doctor slot time is not mapped as per doctor consultation time. So when you studied further, we have seen the doctor waiting time is, we have given the slot time is 15 minutes, but the average consultation time is 20 minutes. So we have made the slot time is 20 minutes. In the next, we have also designed our slot time as per the proposed, as per the procedure timeline of the consultant wise, and we have found a very much improvement in our waiting time. The corrective action that we have taken during the study, after analyzing the baseline data, we have done doctor-specific discussion with team, and Dr. OPD slot has been rescheduled as per the availability. We have excluded the procedure time and IPD round times from the slot time, and it was significantly came up less. We have done the gap analysis between the time differences of 2 slots versus derived average consultation time. And if time difference between 2 slots been modified, queue management system has been introduced, patient waiting time been calculated from the revised slot time for late coming patients. You can see some glimpse of our implementation where we have seen our newly implemented queue management system, HMIS process management system, and our slot time given in the HMIS according to consultant basis. Please refer that number 1. It is the consultation within PAT was increases 57 to 67%, and consultation exceeding PAT decreases 43 to 33%, and our average CAT has been reduced from 55 to 36 minutes. And in our case, it is evident that by reducing every 1 minute of OPD CAT, we are able to increase 0.47% of OPD satisfaction level. That's it. Thank you.
Thank you, Anupam.
Thank you.
Questions, please?
You mentioned about the queue management system and
Yes.
what to say.
Yeah.
I would like to understand, like, what is the base of your data? Like, is it manually taken, or is it from the system?
No, it is comprehensive. It is taken from our HMIS only.
From the?
From our HMIS only.
Okay.
Yeah.
Thank you, Anupam.
Yes.
Was there any exercise of validating the data was done?
What now? Sorry.
Did you validate the data?
Yes, we have validated data. 100% data is system generated, and we have also done a small validation process where we have taken a few cases and we have standard there and collected whether that is matching with our system data or not. That we have been validated.
Thank you.
Thank you. Thank you, CAHOCON. Thank you, Alice.
Thank you.
Thank you.
We move on to the next presenter. From Indraprasth Apollo Hospital, we have Mr. Satish Kumar. Mr. Satish Kumar from Indraprasth Apollo. We'll move on to the, since he's not around, we'll move on to the next presenter, Dr. Saril V.S., Sakra World Hospital. Dr. Saril. The presentation number is AB 514 from Sakra World Hospital.
Namaste, Ohe gozaimasu. The 360-degree Anson First model blends concept of patient for patient safety with Japanese Kaiken for proactive risk mitigation from life-threatening fire and pressure hazards in hyperbaric oxygen therapy, HBOT. This is an amalgamation of Indo-Japanese wisdom. HBOT is a treatment in a closed chamber providing 100% oxygen under 3 times higher atmospheric pressures for 90 minutes every day. In a highly pressurized chamber, HBOT poses serious fire and blast hazards. Historically, 80% of HBOT fire resulted from entry of prohibited items. It's impossible to quickly open the door, hence rapid evacuation is not always possible. Treating comatose patients makes it most vulnerable. So what is the real danger over here? Imagine a fire triangle plus a highly pressurized chamber and you're stuck inside. Boom, it's like a bomb blast. Did it happen anywhere? Of course. These are the photographs from reported incidents in published literature and social media, very scary. And within a few seconds, the entire building comes down. You can see the pre-post analysis over here in the photographs published. This is a recent one in Russian hospital. Very tragic incident where a 4-year-old young boy with cerebral palsy and his grandmother was burned alive inside an HBOT in USA recently. These are the globally reported HBOT fire blast incidents, which has taken away precious lives of 100 human beings. What are the probable causes of such fire blast? We have done a root cause analysis through Ishikawa diagram, and we have prioritized them based on their impact. So what is the real problem here? Already 160 units are operational installed in India, and it is exponentially increasing, but there are no national regulatory guidelines as yet. So our objective is to formulate and implement a total quality management system for HBOT risk mitigation and foster a safety culture. This is the methodology used, and we have developed it through a PDCA cycle. Multiple PDCA cycle by the root staff has helped us to develop the countermeasure. The crux of it is identification of no-go items or prohibited items, similar to the aviation industry. We do it through an NFPA risk assessment algorithm and a Berman risk scoring system, and the staff uses something called as Kaiken-Yoshi, clinically proactively detect and eliminated no-go items. What is this key feature? It's called Kaiken-Yoshi. It's a what-if mindset. It is pointing at a target object by stretching arm and stating out loud and listen your own sound, which is a multi-sensory involvement. So percentage chances of making mistakes is least in pointing and calling compared to only pointing or only calling or only seeing. We have developed an indigenous innovative safety design using this Kaiken-Yoshi. There are 2 levels of it. It's a multi-level KPI safety design. Equipment safety is done completely by the clinicians and not the engineers. The procedure safety done with 4 levels of safety checking and a 5th level of safety checking by a supervisor. And the glaring aspect is the active involvement of patient and caregiver in their own safety checking and declaration of no-go item. This is how we integrate patient for patient safety concept and the patient safety advocacy. This is our gift to the world. We call this as 360-degree safety first model for HBOT proactive risk mitigation, a total quality management system involving all the stakeholders, highlighting bad news first culture. And the results are amazing. And you can see over here that the pre-post hazard identification risk assessment as the risk matrix rating has considerably come down because of the active implementation of human controls, and process controls. The KPI safety assurance, the excellent results for the process compliance, KPI shows the success of very stringent control measures. The most amazing factor here is 158 times vigilant staff has timely detected and averted major disasters. That's why even I am alive today. And this is the machine KY incidents reports, which has increased considerably, which shows the high vigilance of the staff. So in nutshell, 472 operational days, 2,740 HBOT dives, and 0 harm. 99.16% patient satisfaction for HBOT safety measures. These are the sustained strategies. To sum it all up, we have an innovative total quality management system, globally adaptable anywhere in the world. This is our gift to the world, successfully established a robust safety culture from pathological to resilient. Why does all these things matter? First, let us do no harm. So every effort counts, every patient counts, therefore safety first. Thank you. Ohe gozaimasu and arigato gozaimasu.
Thank you. Very nice presentation.
Very nice.
Thank you, doctor. My question is, how many installations do you have of the HBOT at your system?
Yeah, we have one installation till now in the study, and the second installation is getting installed right now in the campus.
All right. So I was just going through the literature. There is immense literature available on all the safety precautions to be taken with HBOT, with all the different, wherever it's been, there is root cause analysis, and all this what you presented is known, what is known to prevent, meaning to ensure there's patient safety. So my one question is, you said you have documented tremendous improvement and all this being pickups about things which could have led to disasters. My question is, when you did the installation of the system, wasn't all this thought through about at the time of installation that we should be careful about doing all this? Or is it that after the installation that later on now you have realized that we should do all this, now you're showing improvement?
Yeah.
Because logically, all this should have been there right at the time of installation of the HPO.
Yeah, excellent question. Thank you. So basically what happens is, yes, in Western countries, most of the focus is given for the pre-installation, the environmental safety and all the gases and everything. So engineering control measures, which comes with the equipment, is done. But in India, what happens is the daily operations. And the most important thing is, like in aviation industry, as I mentioned, the no-go items, identifying and go inside. Like if a small boy takes a small toy car inside by mistake, and the entire thing is over in no time. So the human factor is something which we had to really come up with. And unfortunately, those trainings are not given by any of the companies from anywhere. We also have an US equipment, but unfortunately, that aspect is not given much of an importance. So we had to come up with this similar to an operation theater system. We had to have a KY kind of an analysis. And every time a staff is sensitized, resensitized to use kite and yochi to point at every single object and in a checklist. So all these quality measurements had to be developed by us. And we are now started training other centers in India, and that is our mission. All right. Thank you.
Thank you.
So much, Doctor.
Thank you so much.
Thank you.
We move on to the next presenter from Jaslok Hospital, Mumbai. We have Mrs. Ewell Sarin. Platform presentation number 537. I repeat, 537.
Namaste, everyone. I'm taking up a very common topic, which is a pain point in the hospital, that is the discharge process. Today, our payer mix in a hospital is mainly 50-50%, 50% cash, 50% TPA. Hence, digital transformation becomes very important. Improving patient experience through cashless pre-authorization and express discharge solution is my topic for the day. We all know that manual cashless and discharge delays in hospitals are two tightly woven threads in an entangled web. We all know that the manual cashless is time consuming, it needs verification, approvals, claim processing, and leaves patients anxious. At the same time, delayed discharge not only burdens the patient with prolonged stay, increases the cost, also strains the hospital capacity, and bed management becomes difficult. With the help of DMAC, we defined our problem. We understood that it approximately takes 2 hours for the internal tag once the discharge has been notified by the doctor. And once the bill is sent to the insurance, it takes minimum 3 to 4 hours for the final approval to come. Our aim for the study was to improve the discharge experience for patients by reducing the waiting time, streamlining the cashless formalities, to reduce the discharge time, which was previously 6 hours, to at least 3 hours, encourage adoption of electronic submission to insurance companies by accessing healthcare from anywhere in India, improve and continuous communication with the patient relative in the journey who avail cashless, and lastly, empowerment of the patient by active participation in discharge planning. We identified by the method of fishbone why are discharge delays happening, and we understood that in our hospital we did not have something called as planned discharge. All we had was unplanned discharge. We had discharges happening throughout the day, as a result of which the discharge summaries got delayed. As a result, the bills got delayed, and bills sent to people got delayed. Also, there was no intimation to the patient that tomorrow morning we are getting discharged, or there was no planning of discharge where the patient was involved.
but we adopted this method wherein we ask the patient to scan the QR code, they upload their KYC documents which are OTP validated, and once the patient fills up the data, the link is gone to the doctor wherein they fill up the medical history, the estimated length of stay, the cost, and it is submitted to the insurance company. The insurance company settles the claim and the patient is ready to get admitted. We analyzed that the cashless procedure was manual right from January 23 till we moved on to August, wherein we went to digital. Today, we are completely digital onboarding journey when it comes to cashless. There's an easy access to the portal and the documents can be uploaded from anywhere of India. Patient need not travel to the hospital, and it is an OTP-based validation. The demographic captured by the hospital is with ease, and there's a real-time update to the status of the patient, whether your claim is approved, denied, or there are any queries which are received. Now, every hospital has a discharge process. Once the doctor notifies that you are fit for discharge, the hospital starts their discharge process. So there is medicine indenting, return, credit, there is a visit charge updation, the surgery charge updation, and so on and so forth, till the new dues are issued by the billing department. Previously, our average stat was around 4.2 hours in the calendar year 2022, and we ended at 4.4 hours at the end of calendar year December. In the year 2023, we started at 4.4 hours and we ended up 3.3 hours. Now, we realized that over the last 3 years, our HR said that the discharge notification, the entire discharge process took 6.2 hours and we ended up at 3.3 hours. This year, we started in the August when we went completely digital. From 4.2 hours, we came down to 2.4 hours. Now, how did we do that? What did we do? So we worked on 3 aspects: the process, people, and technology. In people, we started training them the onboarding digital technology. In terms of technology, we started making patient a part of the journey, and we started sending them an SMS 24 hours before that tomorrow is their discharge. In terms of process, we started discharge planning. We stopped the discharge after 2 p.m. so that the discharges are in time. And we started sending interim bills to the insurance company, so the last minute there are no ambiguities. We started monitoring this week on week, and we started presenting this data in our CQI meetings, in our patient experience meeting, and our director coordinator meetings, and we ensured that there's no gap, and the gap is monitored. In the last, we ensured that these help the patient, the hospital, and the staff. Patient, because the patient can fill up the process, pre-auth form anywhere from in India. There's a faster discharge process. There's absolute transparency, and patient is empowered. In terms of hospital, there's a reduced wait time, the bed management improved, there's enhanced accuracy, and of course, the better patient experience. In terms of staff, how did it help? It reduced the workload, reduced the phone calls, reduced the paperwork, and better satisfaction. Thank you.
Thank you. A nice mention. Discharge is always a concern for every hospital. Any question?
Yeah, you have mentioned that your intention was to reduce it from 6 to 3 hours, right? Now, is it specifically for the TPA patients?
Only TPA patients.
Okay. And what was the TAT for the non-TPA patients?
So 1.5 hours.
I think you have addressed the pain point of all hospitals. So thank you, Sanin. Thank you.
One question. Just one.
Do you have question?
Post-intervention, were you able to collect patient feedback?
Yes, ma'am. We have, in fact, Google reviews because that goes public. So we have reviews wherein people have mentioned that we've been associated with the hospital from decades, and we can see a remarkable difference in the discharge process.
Any other tool or any other methodology being used?
So, ma'am, we have CRMs wherein the patient can give their feedback. We have discharge tabs, and we have Google reviews. These are 3 ways where we collect feedbacks on. And this is presented in the CQI.
Google reviews might not be, to the point, but like Madam has asked.
So the CRM has a detailed questionnaire.
That is what.
Yes, sir. Thank you.
Okay. Yeah. Thank you.
Thank you, Ms. Iral. I call upon the next speaker, Dr. Akila Rajkumar. She's from Dr. Rela Institute and Medical Center. Platform number, presentation number 371. 371. Dr. Akila.
Morning, everyone. Myself, Anusha. Dr. Akila couldn't make it up. I'm presenting on behalf of the team. Myself, Anusha. I'm working as a quality manager in Dr. Rela Institute Medical Center. The topic which we have chosen for our process improvement is a rapid, effective, and user-friendly analysis of CSF, mainly for your total cell count and differential cell count using an automated analyzer. As we all know that CSF analysis is done for your clinical diagnosis or for ruling out any infections in the post-op cases. We're done for different modalities. The focus what we have taken is your CSF total count and differential count. It is the traditional, that is a conventional method is done with your Nuba chamber, cytospin, and smear examination. The challenge with this is for the Nuba chamber, we need a trained and skilled personnel, and it is time consuming also. If the technician is held up with other things, they won't give importance for the CSF sample. We all know CSF sample is given much important and is very crucial. We cannot do the procedure again to get it from the patient again. The commonest challenge with the turnaround time has been explored with us. The objectives which we have taken is to analyze the turnaround time between your conventional method and the automated method. The difference between here is an improved Nuba chamber analysis for cell count and an automated method for a cell count analysis, and other two steps remains the same, that is a cytospin and the smear examination. We have included total 154 samples for the entire calendar year, and we have excluded the samples which has been received in the lab in the non-working hours. And the simple methodology which we have adapted is in PDSA. In the planning phase, first we started with the brainstorming on analyzing the pros and cons between both the methodologies. All the possible risks and the things have been listed out with an FMEA methods, and each against this, what are the best possible alternatives. We have explored the literatures and other things, what can be done and what are the best feasible methods with us. And in do phase, with the resources, the existing equipment in our laboratory is able to do with the automated analysis. Only thing is we have to talk to the vendor and the LIS team to get the software integrated and upgraded. And the reagents required were also being explored with the cost factors, and all those things has been arranged. The staffs have been trained with the newer technology, what need to be done with the automated analysis process. And we have validated the methodology which you are going to adapt. In the study phase, we have monitored the path between both the methods, and we have noted a decreased trend in the process, and the challenges with the man, materials, and other things have been addressed. And in ACT, we have implemented the automated analyzer process, and the process change have been communicated with all stakeholders, and the necessary policies, documents have been changed, and the clinical team also been communicated on the reductions in the TAT process. I've just got a small video on the process, how we have rolled out. To start off, this is a normal process, how we receive the labs process in the HIS and the LIS to get the accession number, and then it has been processed. And the sample has been taken in the RIA vial, and then it has been mixed with the reagents as per the recommendation, and the mixture has been, OTAX's process has been completed. And in the whole blood analyzer process, we have to just change the module into the CSF. And once we load it, you will be able to get the results within 30 seconds on the monitor. So that is the efficiency which we have taken up. And followed by that sample has been sent for your cytospin and your Leishman stain, and the result has been reviewed, verified by the pathologist, and the final result has been released in the HIS for the clinical team to get it accessed. And we didn't stop only with that. So we are thinking on what else to be the next thing. Can someone? It's frozen. Can someone close the video?
You have only 1 minute.
Can someone close the video for me? Yeah, it's done. Thank you. So this is with the data, we could see that actually almost 50% of a reduction in the TAT process. In the first half, that is the first 5 months, we can see that as an almost 4 hours on average, we were able to maintain in 3 hours and other things. In the second half, we were able to maintain in 1.5 hours. In the mid-May is the intervention time where we implemented the automated process. And with the sustenance measures, we didn't stop only with this, what we have achieved. And we have monitored in the first quarter also, and the TAT has been able to be maintained less than 1.5 hours. And we have checked on the things. We have continued with the samples which has been received in the night time, where we are able to release the provisional report for the samples received in the night time. To conclude what we have done, under efficiency, we were able to release the results with a higher precision and reliability, and the TAT has been able to be maintained in less than 1.5 hours for the entire CSF cell count, total and differential count. Effectiveness, we adopted the latest technology available and the error-free process, because with manual, we have a higher chance of errors, and it has an inter-observer variability. And ultimately, it resulted in an increased consultant satisfaction because they are able to receive results on time, which is getting them into a right direction of clinical treatment. Economical, we didn't increase the cost on the thing which is going to be billed for the patients because the reagent costs and the other things have been analyzed. We are maintained with the same cost which was there in the previous before May, and the same cost is being continued in the final billing process.
It was a nice presentation.
Yes.
Any questions?
Nice presentation.
Yes,
Just have one question. What
Yes,
was the cost to the organization in implementing this project?
Ma'am, we didn't have any additional cost, ma'am, because the existing equipment is compatible with it. Only thing is we have to talk to the company persons, get the software integrated. We didn't have any cost things to the management, ma'am. Only thing is the margins which the organization is going to have a profit from this, and this is actually a little less, but still it is, if you see in a month, we get hardly 6 to 8 CSF samples. So management also agreed with no cost in the pricing, we are able to implement this process.
So it was a software which was implemented in the.
Yes, ma'am. That's technology which we have used because with the existing equipment, we are able to adapt that technology for the automated to the automated process. Because the traditional thing, if you do, actually it takes about, if the person is skilled and other things, if he or she is confident enough in releasing a report, they can able to release in 30 to 45 minutes. But with this, actually, it doesn't require a skilled people because it's just a mixing of reagents where we are able to get the results in 30 seconds.
What was the cost for the software?
Sir?
What is the cost for implementation of the software?
Cost for software, sir?
That integration which you talked about.
Cost for the software you're asking, sir?
You said you didn't have to buy any new equipment.
No, sir. This actually in the software which we have integrated in that equipment, we have two modes. One is the whole blood analyzer, another one is a CSF analyzer, which we are not using. The existing software, we have spoken to the company person and integrated it, and we started implementing it. It was not an additional integration, which was already integrated, but we were not using it with the challenges with it.
So you had an equipment which had the facility.
Yes, equipment which is feasible for that methodology, but we were not using it.
Okay, you started using the equipment.
Yes, sir.
Okay, completely.
Only thing is we have the challenges with reagents and other things. We have to get QCs and other things, which we have explored after this. And
that is what Madam asked, like this, every integration that happens, there is a cost involved.
No, sir. In this, actually, the existing one has already the module.
And the reagents also. So you have to do a costing analysis.
Yes, sir. Reagents.
What is happening is very fundamental.
Yes, sir.
Software has to be revised. The present existing software has to be revised. So that revision also requires cost.
No, sir. The equipment what we had is Advia 2021i. So that has a module which has two things. So in the video also I've shown it. Only thing is when we are starting off a machine, it has two things: whole blood analyzer and CSF analyzer, which we were not using. Because the
Advia is from Siemens, na?
Yes, sir.
And that's why I'm telling. In the Siemens analyzer, whenever you are opening up one particular extra facility,
yes,
you have to revise the software. Or rather, you have to reinstall the new software.
Upgrade.
Software version changes.
Sir, that equipment actually we got, and after COVID we have gotten, in the 2022 we have gotten. But that time actually they have given the provision, but we have just upgraded the software, but we didn't go for introduction of the CSF analyzers.
The software did not
in this project, we didn't go for it because already there it was initially installed with along with the initial software when we have upgraded the machine to the next analyzer. So from the initial, we didn't have. Last 2 years, that machine was with us when we couldn't use it. And after we were looking on the process.
That only.
It can be
So that
integrated,
means
yeah.
for updatation, you did not have to pay anything.
Yes.
It was automatically company did.
Yes, sir. Already it has been installed, but we have started using.
No. See, I'm telling you, flow cytometry.
Yes, sir.
Flow cytometry, people, they sell it, na? They have got a 9 channels, they have got 11 channels, they have got a 13 channels.
Yes, sir.
In actually each machine, 9, 11 and 13, all provisions are there.
Yes.
The moment you want from 9 to 11, then you have to upgrade the software. The moment you want 11 to 13, again you have to upgrade the software. And each and every upgradation requires a cost because the company charge you. So
Yes,
that was the question he was asking, whether for this upgradation, you had to pay them or it was free of cost.
No, sir. This was.
So therefore, see.
This was when the machine has gone
Lucky.
for the latest version that was given.
Siemens has been extremely good with them.
Yes, ma'am.
Let's take it.
Thank you.
Thank you.
Thank you.
well handled, I should say. So she had a barrage of questions to handle. I call upon Dr. Malti Murugesan from Meenakshi Mission Hospital and Research Center. And this, including the previous speaker, this was the diagnostic category. We have three presenters from diagnostic categories. Dr. Malti would be presenting the second one. Our platform presentation number is 618. 618. Over.
So very good morning all. I'm Malti. I'm representing my hospital infection control committee in sharing an experience of an outbreak management in a neonatal intensive care unit. As we all know, healthcare associated infections are a growing concern, especially post-COVID-19 pandemic that caused a lot of increase in length of stay, mortality and morbidity among patients. In a hospital setting, if we isolate an unusual microbe, for example, Burkholderia stenotrophomonas, or a common microbe with a certain resistant pattern in a closed unit, then it could signify an outbreak. In such situations, as we all know, most of the time, the infection is from the hospital environment or from a point source inside the hospital. In such situation, it's very important that the environmental surveillance needs to be done by the infection control and microbiology team, which helps as a proactive tool in identifying the source and to contain the outbreak. So this also helps to link with the clinical data to have an evidence-based strategy in implementing the future protocols also for a hospital. So the aim of this presentation is to describe our experience on investigation and management of an outbreak in neonatal care intensive unit. So in the month of Jan and Feb 2023, over a 3-week period, we got an outbreak report from the primary neonatal team that there is a cluster of neonates with blood cultures growing, certain resistance pattern of Acinetobacter species, and there was one child with Burkholderia capacia that was notified to us. It was surprising for them because their most common pathogens were Escherichia coli, Klebsiella, and Pseudomonas, and they never got Burkholderia and Acinetobacter so far. So as per the hospital protocol, we started the outbreak investigation. We first confirmed the outbreak with the laboratory and primary team, and then a briefing was done. A case definition was set up. Line listing of cases was done. Then we looked for the similarity among cases to identify any source. As per the protocol, we did a review of literature to look for the similar kind of outbreaks, whether there is any Burkholderia that has been reported in NICUs. We started doing auditing and inspection of infection control practices, and we also simultaneously started an environmental surveillance. So doing a surveillance helps to identify, but most of the times it's very difficult to find the source. And doing an audit helps to find the gaps and implement the control measures. So this is the protocol as per the hospital. So as per the protocol, we made a case definition over a period of 1 month to find out who are all being infected with Acinetobacter and Burkholderia. We made a line listing of cases. We wanted to look for similarity, whether all are inborn cases, whether it is a vaginal delivery or emergency LSCS or elective LSCS. That helps us to locate the source, and we wanted to look at whether it is an outbreak from the labor room or outbreak inside the neonatal ICU. So we tracked the admission date and the culture rates. And in addition to this, we did a lot of other tracking like procedure tracking, medication vial tracking. We couldn't put it in the slide. And we also looked at the organism phenotypic similarity. An infection control audit was started looking at the hand hygiene, bundle care, neonates, breast milk sterility testing, and feeding practices. We also looked at the review of literature. As there was one Burkholderia, it was surprising to read the review of literature that Burkholderia and Acinetobacter can be there and even in the ultrasound gels and the lignocaine gels. So this helped us to look like Sherlock Holmes when we have gone for the audit in the labor room, gynec OT, and neonatal ICU. We did surface swabbings. This is a very routine swabbing that we do it in the high-touch surfaces like incubators, warmers, phototherapy unit, breast milk feeding area, and the resuscitation unit in the labor room on OT. In addition to this, when we went for the audit, we looked at there are certain solutions that is being used for flushing has been kept open. There was sterile waters that was used for humidifiers was left open. So we also wanted to check whether there is any source of contamination. We took that. As per the review of literature, the lignocaine gels and the ultrasound gels were also taken. So this is a report that is showing that most of the surface swabs has no growth. There was one water that has growth. Surprisingly, the PV gel, that is a lignocaine gel used for pervaginal examination, has Acinetobacter species. So because it's grown, we did a surveillance in other areas also like radiology, and that has also grown Klebsiella species. The reason was there was a procurement of 5-liter gel and people were transferring the gel from this to the reusable bottles. So we stopped that from the ward pharmacy and we asked them to procure single-use disposable and discard this container. Instead of having a 30-gram Lox gel from the ward pharmacy, we asked to implement 10-gram single-use Lox gel, which should be in the patient billing in the pharmacy side. So all these were implemented and the findings
conclude fast.
And the findings were communicated in the HIC committee and also from that, we found that after the implementation of this, there was no Acinetobacter or Burkholderia species infections in the neonates. We still have sepsis. We accept that, but the common pathogens that we encounter is E. coli, Klebsiella, and Acinetobacter. So to conclude, contaminated ultrasound or lignocaine gel can be a potential source which cannot be overlooked. This shows the importance of clinical microbiology laboratory and infection control team collaboration in instituting the infection control measures to control an outbreak. So these are my references for the break, and I thank you all.
Thank you. Any
Thank you.
questions? One question allowed, one question.
Thank you. A good presentation. So to reduce the sepsis, you have done a lot of environmental surveillances and also audits. So these audits were part of the environmental surveillances or it is a separate audits?
Ma'am, it's all done at the same time. Okay. So the first day was the audit. Based on the audit findings, we started doing the swabbing.
It's very difficult to understand an organization which is so good and apt in outlook investigation, how they can allow a 5-liter, bottle of 5-liter lignocaine gel. I mean, sorry, not lignocaine gel, right? No, lignocaine gel. Oh, you used what? 5-liter gel, ultrasound gel. How it was possible? Because it has to go through the D&T committee or infection control committee. How the order was placed, because see, in a good setup, an NABH setup, accredited setup, it is actually committee who decide for the kind of purchase to be made to avoid infection. So in what the infection control team was doing or the D&T committee was doing, they were sleeping or what? It is not possible na, to buy a 5-liter gel, because everybody knows that gel is a major source of NFGNB, that is non-fermented gram-negative bacilli, which you are dealing with non-fermented gram-negative bacilli, that is Burkholderia, Stenotrophomonas, Acinetobacter, all these things are similar DNA homology. My question is very simple, that this outbreak is actually made outbreak. That is your hospital made outbreak. This outbreak is not something which is uncommon. So you should have been,
Yes,
you
sir.
cannot make a story and then investigate for that. So this has become like that to me, that already hospital system was not there. They were not checking and suddenly it happened. Then they did the outbreak and then now taking the credit. I'm sorry. This
Can I answer,
actually how the infection control should work.
Can I answer, sir? So during COVID-19 pandemic, the infection control officer dropped out and I was recruited in the year of 2022 and we critically reviewed all the pharmacy recruitments and all the solutions, everything. So this is one example to show that the infection control team, I agree with Sankar sir, that they should be a part of pharmacotherapeutic committee. They should be a part of materials committee. The multidisciplinary committee should be there. So I really thank my administration for allowing me to share this data. I hope you all will agree that most of the institution will not allow the data to be presented. But this is one example that mistakes can happen and it's very important that administration should support someone like an infection control professional to implement policies. So based on this, we actually implemented now all the pharmacy new recruitment products, even antibiotics. One vial will be sent to the microbiology department and we test it. And during our surprise visit also, we randomly pick especially the antibiotics, they mix and store it in the refrigerator. We go and take it and we do a sterility check. So we all learn from our mistakes and lessons. So I sincerely thank my hospital for allowing me to present this data. Thank you.
Thank you. Thank you very much.
Yes. Right. Thanks, Dr. Marti. We are constrained for time. Sorry about that. Next session has to begin. We'll move on to the next speaker, Dr. Ashwini Jogade from Dr. Rela Institute and Medical Center. Dr. Ashwini. Okay, we move on to the next category, which is the last category about students category. I call upon Miss Karthikayani Krishnaswamy from the University Malaya Medical Center. Her presentation number is 239. I request the jury and the audience to restrict your questions because we need to begin the next session. Thanks.
A very good morning to juries. This my project study title is on Comprehensive Unit-Based Safety Intervention Program for the Prevention of Falls in Hospital. As we all aware that falling is a major public health problem with sequelae that range from minor abrasions to most severe till can go to mortality and morbidity. So inpatient fall and injury incidence varies according to the characteristics, with medical surgical patients are at higher risk of and also intensive care patients. So the acute care patients may be at risk of falling due to newly altered mobility, mental status, medication side effects, history of previous falls, frequent toileting or in unfamiliar environment in hospital setting. So hence, in this study, I adopted safety attitude questionnaire, which was to explore the relationship between safety, climate scores, and patient's outcome. And it has a good reliability and validity tested. In this study, comprehensive unit-based safety program was adopted from Johns Hopkins Hospital to align the culture change, to identify, to eliminate patient safety hazards, and improve local culture. The objective of this study is to develop a system that identifies patients who are at fall of risk during admission and implement the interventions to promote the best outcomes. It also to evaluate the effectiveness of comprehensive called as CUPS in improving patient safety culture and reducing falls in a teaching hospital by implementing an interdisciplinary program as well. So the method used, this study is implemented in a medical ward, hematology ward in a teaching hospital. All eligible participants are the healthcare providers, including even the housekeeping staffs. So we adopted this CUPS model, which have a science of safety education. So there's a lot of elements into it. This CUPS, I will explain in next slide, which is an interventional and pre-post study as a quality improvement study. Implementation research framework as established by the WHO Alliance for Health Policy and System Research. Managed to get permission from this Johns Hopkins. It's the evaluation process guided by the UK Medical Research Council, initiated in a medical ward. This CUPS is developed by patient safety researchers at Johns Hopkins to improve local safety culture and to learn from defects by utilizing a validated structured framework. Is designed to target the work of unit level, engaging and empowering staff in identification and elimination of patient safety hazards. CUPS needs teamwork, communication, and engaging senior executive for the improvement of patient safety. And the goal is to create sustainable patient safety improvements by creating a culture of safety. So this is using a PDCA model, the process of CUPS intervention in our setting, in which we brainstorm all the staffs by having an online Schoology module structured course train. Is a one-day program in whereby we call the stakeholders to come and engage themselves in the training and has a brainstorm about the issues and factors they are handling in their team with their ward, with the factors and all the barriers and challenges. And we also have included senior management, our top management and leaderships to have their supports. And we go down to the ground floor to all the staffs by showing them, giving them the pre and post test after the Schoology module. And also we include the patients and family members because we also share a lot of materials like posters, videos, pamphlets to them. So this is the safety attitude results based on the radar plot. Pre and post has been done to all the stakeholders in that unit, which shows a huge difference from the 6 domains of teamwork, safety, climate, job satisfaction, unit perception, hospital perception, and stress recognition. And you can see the pre-intervention, the fall rate was 7 because this is a small unit of hematology ward. And post-intervention, we managed to bring down to 0. That is the longest fall-free days during and even pre-pandemic as well. So even until now, it started from 2018 and until now it's sustainable with only 1 or 2 near misses cases was identified. So as a conclusion, CUPS leads to sustainable changes in quality of care and practice of healthcare providers. And we would like to spread the interventions. Hence, currently we're spreading that fall prevention using the CUPS model to other units in our hospital, including emergency department, and expanding the collaboration to reduce patients' harm. So it is, thank you.
Thank you.
Thank you, ma'am. Thank you so much. Any questions, please? This is the last session. No questions?
Thank you.
Thank you.
Okay, thank you. Thanks.
Thanks, Ms. Karthikeyan. I call upon the last speaker for the day, Dr. Prashant Nag. Not for the day, for the platform presentation. Dr. Prashant Nag. He's from All India Institute of Medical Sciences and his platform presentation number is 802. 802. Dr. Prashant.
Very good morning to everyone. Respected jury, my topic for the study was we conducted a study to explore the perceived impact on accreditation on healthcare quality and its associated costs among the healthcare organizations in the country. The aim was, the objectives were to understand the ingress of accreditation, to understand the perception of accreditation, to identify the various cost centers which are related to accreditation. We had to prepare a study tool for that. The study tool formulation undertook 3 steps. One was systematic review, focus group discussion, and the phase and content validation. For the systematic review, we choose 4 key words: healthcare quality, cost, accreditation, and patient safety. The databases of PubMed, Scopus, and Cochrane were explored. 15,000 plus articles were found. After deduplication, the title screening was done for 10,988 articles and then 1,188 full abstract reviews, full text for 2,247 articles, and finally 66 articles were included. Ryan software free version was used for this. A focus group discussion, there were parameters which were found from the systematic review. Focus group discussion was conducted by internal experts from the Department of Hospital Administration at AIIMS Delhi, from subject experts from the external side, from Amrita, Medanta, Apollo, ILBS, and various other organizations. And with that, we, after putting forth the parameters for the focus group discussion, we came out with semi-structured questionnaire. After the phase and content validation, the questionnaire was a little elaborate with section A, section B, and section C. Section A consisting of background information like hospital specialty, ownership, accredited organization by NABH, JCI, or NQAS, and by the how many beds does that hospital have. For the inclusion criteria, we had only chosen the hospitals which were above 50 bedded hospitals. The exclusion also accredited by NQAS, JCI, and NABH. The exclusion where Ayush centers were excluded, less than 50 bedded hospitals were excluded. On the sections B, we had questions related to impact of accreditation. We questioned them on the Likert scale. 7 was being strongly agree and 1 being strongly disagree. 91, we total received 120. The Google form was distributed to more than 700-800 hospitals across the country. We received 121 responses. Out of that, 91 responses were analyzed. The benefits of accreditation, the results showed that there were benefits of accreditation, like the accreditation helps in systematizing hospital processes, reduction in medication errors, improves communication, improves documentation, enhances the hospital's image, improves trust with staff. We have a positive impact towards reduction in the mortality rates, decreased infections, improved work environment, decreased conflict, patient satisfaction, staff satisfaction, better problem finding. We had driving factors which were found out from the results of the study were leadership involvement, staff training, educating physicians, fostering a learning culture. The restraining factors which were seen from the study were staff shortage, staff resistance to change, staff wages and incentives, not providing them incentives was also considered as a negative restraining factor. High workload, increased pressure from the leadership, partiality from evaluators, limited physician engagement was also a part of the study, which told us has restraining factors. We also identified cost centers. The cost centers which were perceived by the hospitals we surveyed were cost centers for statutory requirements, skill training and development staff, signages, structural safety. There was also costs involved with achieving accreditation, maintaining accreditation, retrofitting costs, repair costs, renovation costs. Also, we asked them the key performance indicators, where they're showing downtrend, uptrend, were they not measured. It was mentioned that there was a downtrend reduction in rate of needle stick injuries, surgical site infection rates, percentage of medical records having incomplete documentation, return to ICU within 48 hours. And there was increase in compliance with hand hygiene, increase in compliance with surgical safety checklist. These were the results which were noticed from the study. Therefore, jury, I conclude by saying that accreditation is needed because organization must meet certain quality standards. The accreditation process also needs ongoing evaluation. Cost of accreditation was slightly higher compared to on the JCI side compared to NABH and NQAS. Accreditation in India is widespread with the home ground standards of NABH and NQAS. Despite various cost concerns, the key performance indicators showed a drastic improvement. Thank you one and all.
Thank you, Ratnag. One question from the audience.
Usually when you say systematic review for the things, it applies to RCTs and all those. When you have things which are related to accreditation,
sir,
the 66 articles that you chose,
yes, sir,
what kind of studies were they? They would be their experience kind of thing as to what's missing. How many of those studies are just something written theoretically? What are the 66 studies? What kind of research articles were they?
So the 66 study articles which were finally included, almost 9 articles from them were systematic review itself, sir. And there were other paper publications, guidelines were also this.
So rather than, I'm not really sure, but then I don't think this would be a systematic review. It's like a review of literature for what is the impact of accreditations.
So
you've taken another 9 systematic reviews and chosen the articles from that and what they found.
Yes.
And then another set of different, so it's a mix bag. So this would be like a review of literature and what you found, rather than
yes,
I'm not sure whether you can actually call it a systematic review.
Okay, sir.
Thank you.
Thank you so much.
Thank you. I'll request the jury members to come onto stage to join the moderators for the session. Dr. Amita Marla, Dr. Pratish Ravindran, Dr. Arijit Ghosh, Dr. Jeet Patwari, and Dr. Nisha Nair. They've been in the audience sitting there through the last 2 hours in the morning. I don't know whether they had their breakfast, but I'm sure so do the moderators, patiently going through all the 17 presentations that we had. I request you to join on this stage, please. We'll have a photo shoot. Near the CAHOCON emblem, we'll have a photo shoot with the moderators as well as the jury before we begin with the next session. Thank you, Dr. Sujay Ranjan Deb, sir, and Dr. Suprana Sen Gupta, madam, for for guiding us through the platform presentation. There were glitches, but I think we managed well.
Thank you so much.
Yeah,
It's been a pleasure. Thank you, Kaho, and thank you all the representatives. It was a very enriching experience for all of us. Thank you, the jury, for taking the time and the patience. Thank you so much.
And also, I thank the audience along with the participants who patiently waited for their turn and spoke so well. All the presenters, I should say, I need to give them a round of applause because they all stuck to their time. They presented well. Thanks a lot. Well done, people. We move on to the next session. I'll request Dr. Jay Lakshmi to please.
Good morning, ladies and gentlemen. Warm welcome to day 2 deliberations of CAHOCON 2024. This is a very auspicious day for healthcare as we celebrate the World Health Day 2024. So the theme for this year is My Health, My Right. The theme highlights an important human right, which is access to good healthcare, education, as well as information. CAHO takes every effort to fulfill them by empowering healthcare systems to be more efficient, effective, economical, and equitable. Let's begin today's session, which is session 10, by learning from other industries or other countries, sorry. To chair this very, very important session, may I invite to the dais Dr. Ravindra Jagastoti from Malaysia. Dr. Jagastoti is a former president of ASQA and chairperson, International Advisory Committee of CAHO. He has been in many technical committees of the Ministry of Health of Malaysia and has vast experience in this area of excellence in healthcare. May I also invite our eminent speakers for this much awaited session, Dr. Kader Marikar, former CEO, Malaysian Society for Quality in Healthcare, and he has been directly involved in the development and implementation of the Malaysian Healthcare and Hospital Accreditation Program since 1996. And Dr. Shin Ashiro, we have him as an executive board member of Japan Council for Quality Healthcare. With his areas of interest in patient safety and public health, he has been awarded for the launch and operation of national-wide adverse event reporting and learning system on medications and medical health institutions, as well as community pharmacy. As a gentle reminder to the chairperson, as well as the speakers, to keep time, and to the lovely audience here, to please keep your mobiles on silent. Over to chairperson, Dr. Jagastoti, sir. Over to you. Sir, over to you, sir. Jagastoti.
Thank you. Good morning, everyone. Let's get moving. We are running a bit short of time. I'm very pleased that CAHO has included ASQA in organizing this session. One of the aims of ASQA, as in CAHO as well, is to share knowledge, bring a platform so that more people can hear what is being done in this region. And so for that, we have two eminent speakers. So the first speaker will be Dr. M.A. Kadar Marikar. Yes. No. Dr. M.A. Kadar Marikar, who is the former CEO of the Malaysian Society for Quality in Health. Very experienced person who was involved with the initiation of the quality movement in Malaysia. A lot of experience and I'm sure a lot of lessons to share. So take it away, Kadar. You have about 15 minutes or so.
Thank you, Dr. Ravi, for the introduction. Thank you to CAHO for inviting and giving me the opportunity to share the Malaysian Accreditation Program with the audience. Good morning to everyone. Now, I'll be sharing on the Malaysian Healthcare Accreditation Program. And in Malaysia, we actually started doing, We actually started doing accreditation only in 1995. But prior to this accreditation program, the Ministry of Health has actually put in place quite a number of quality assurance programs since 1995 to 1996. So a lot of quality improvement initiatives have been started, and this actually became the building blocks for the accreditation program in the whole country. So activities like mortality, morbidity reviews, incident reporting, prevention and control of infection activities, promotion on the use of evidence-based clinical practice guidelines, quality control, innovations, performance indicators, perioperative mortality review, all have been put up in place in most of the public hospitals. And this is actually the building blocks for quality towards moving forward towards ensuring organizational quality, and that's where the accreditation programs actually comes in. And at the same time, Ministry of Health have also introduced quite a number of quality documents like the policy for quality, the mission for quality, the objectives for quality, as well as the putting in place the organizational structure for quality within the Ministry of Health, putting it up at the national level, at the program level, state level, hospital, as well as the institutional level. At the same time, it was all expanded to the other programs like public health in 1990, the pharmacies in 1990, as well as the dental 1992, and the engineering services in 1992, as well as the lab 1992 as well, and training and manpower division in 1996, and planning division 1997. So moving on, we also developed the strategic plan for quality in health in 1998. And this is where in this document, it states the requirement for us to establish organizational quality, and that is where we are moving forward towards developing an implementation of the hospital accreditation program. We started with the hospitals first. During the strategic plan, we actually also produced 14 quality improvement manuals to support the activities of the quality activities within the nation. So we initiated the accreditation program in healthcare in 1995. We had a national consensus whereby we agreed that we should start establishing standards for healthcare services, and we need to focus on hospitals first. So that's how hospital accreditation came into existence, and we actually seek the participation from the private sectors as well as the universities to actually get involved with this whole accreditation program. So this is actually a smart partnership between the private sectors as well as the public, as well as the professional bodies. Prior to that, we also established the framework for quality that we wanted to adopt, and we actually adopted the Avidis Donabedian framework for quality in health, and it focuses on putting structures, process, and measuring outcomes. At the same time, we also identified the dimensions of quality which we should focus in our service standards that we are going to develop. So we actually thought of look at the various documents, and we have settled down with the access that needed to be addressed, safety issues, safety of the staff, safety of the facilities, safety of the processes that we are going to adopt, effectiveness of the services, efficiency, as well as providing patient-centered care and looking into timeliness and responsiveness of the services. So that's how we actually move forward into getting up the hospital accreditation program. So that smart partnership between public and private sector was very successful. And this actually allows the birth for the Malaysian Society for Quality in Health, which is actually a non-governmental, non-public, non-governmental and not-for-profit organization, which is registered with the Registrar of Societies. So this is outside. This is a body that's going to conduct the accreditation program, and which is not part of the Ministry of Health. This is an impartial organization. So they're going to assess public, private, as well as university hospitals. So that's how it became as an entity by itself. But we do have the MSQs have got its own constitution and its board members who provide the stewardship for the organization. Now, moving forward, we actually then start looking at developing standards. So we look around the world and see what the existing standards at that point of time, and we actually settle with the ACHS, earlier version of the ACHS, Australian Council of Healthcare Standards, which we later, that was something very familiar with us, and we later customized the set of standards, and eventually we developed and formed our own set of standards from that origin. And we actually implemented the first set of standards in 1999, and we had the first hospital accredited in February 2000. And the focus of our standards are on these areas: the governance, leadership, and direction, looking at human resource development and management, looking at policies and procedures, facilities and equipment, safety and quality improvement initiatives, as well as some special requirements for specific services. Now, the philosophy of our accreditation program is this is a peer review validation process, and it is not an audit exercise. It focuses on education and better compliance to the standards by the providers, and it enhances staff and patient safety, as well as trying to create a creation of quality and safety mindset or culture within the healthcare providers. And at the end of the day, what we are expecting to see is improving and providing safer outcomes of care. Now, the first and second edition of the standards, now we are trying to look at public as well as private. All the initiatives that I have mentioned earlier on are well implemented in the public facilities, but it is not in the private sectors. So we have to make sure that all public as private are both at the same wavelength. So we actually, when we developed the first and second edition, we only focus on putting structures and process in place, not looking at outcomes, because outcomes have not it's not a practice in the private healthcare yet. So we need to start developing training programs to ensure that the private sectors will come on board and looking at performances as well. So that actually took us about 8 years before we focus on outcomes, and that is actually the third edition standards. At the same time, the Ministry of Health also came out with the Private Healthcare Facilities and Services Act 1998, as well as the corresponding regulation came in 2006. So this actually helps also to strengthen the whole accreditation program, and the licensing requirement for private hospitals became the minimum requirement for accreditation, and accreditation goes beyond licensing requirement, because the licensing requirements they focus on structures issues rather than process and outcome. So that's how the third edition then was developed, where we actually refined the refinement of the second edition and implemented the third edition in 2008, where we actually now address structure, process, and outcomes with generic outcomes at first. And that is very simple, like mortality, morbidity, complications, so that people can understand, and we improve it incrementally. From then on, we're actually looking at compliance to policies and procedures, establishing quality assurance facilitators in the hospital to support the program, training on key performance indicators, incident reporting, all the quality improvement initiatives that are not available within the private sector, so that all of them can come on board and participate in quality improvement activities. And then MSQH prepares the standards for organizational assessment by ISQA, and it was later certified for all the three programs. So we actually took time to ensure that we get ourselves certified with ISQA. So we took about 8 years before we could do that. At the same time, we also developed our surveyors training program. We've refined that, and we actually increased the numbers of surveyors as the numbers of participants who comes in, hospitals that come in for accreditation, slowly increasing. Though it is a voluntary project, a voluntary program, but the uptake from public as well as a private is very supportive. Especially the Ministry of Health actually had a 3-yearly contract with the with the MSQH to actually accredit 100 hospitals every 4 years. So they actually just renewed the third contract for the next 4 years to accredit about 100 over public hospitals. At the same time, the private hospitals is taking advantage of it, because the government actually promotes medical tourism in the country, and it is a requirement. All private hospitals that promote medical tourism have to be accredited. And so the national program becomes one of the favorite, because it is much cheaper, more cost effective as compared to foreign accreditation bodies. Now, then the fourth edition came in,
we actually refined further the third edition in 2012. And then the fourth edition, we introduced the National Specialist Register for both in our standards. And that then came along the credentialing and privileging requirement, credentialing and privileging process. So it is already there in the fourth edition. And at the same time, we also ensure that all tertiary labs must be ISO 15189 certified. So that actually moves forward the requirements for laboratory. At the same time, we also move forward to get our fourth edition standards as well as the ISQA assessment for organization as well as the training programs. In fact, in the second cycle of our ISQA assessment, we had the organization and the service training program being done together. Then came the fifth edition, which was where we actually refine and upgrade the fourth edition standards and introduce risk management for all services, as well as the hospital-wide risk management policy. And at the same time, we introduce a new quantitative rating scale for the criteria for compliance, and also introduce evidence for compliance for all standards. And we also introduce a new format for the standards and the assessment tool. And also at the same time, we introduce the IT requirement for the whole program and further refine the credentialing and privileging process, because now it is now a re-privileging process. At the same time, we also move forward for the ISQA assessment. Now in the sixth edition, now we are currently in the sixth edition. So new services were developed and we refine our medical as well as surgical standards, specific KPIs for all these services. There's a mandatory requirement that every service must have at least 2 KPIs to be addressed. And then we also introduce the requirement of healthcare facility certification for engineers working in the hospital. So this is now a mandatory requirement. And then furthermore, we improve our IT systems to make sure that we are going paperless as we move forward. So at the same time also, we improve higher requirements for full 4-year accreditation status, whereby currently in the 6th edition, prevention and control infection is a mandatory standards where you need to pass. You need to achieve more than 60% compliance for you to get a full accreditation status. At the same time, we also move forward with our 6th edition and getting the ISQA certification. And we are now currently preparing for the 7th edition of our standards, and we'll be addressing new requirements. And one of the things that we were thinking of putting in is the tracer methodology. So all in all, in fact, we have improved incrementally for every set of standards so that we provide assistance and support for the hospitals to conform to the MSQH accreditation standards. Thank you very much.
Thank you, Dr. Kadav. Thank you for taking us through the history of hospital accreditation in Malaysia. You can see that it is a voluntary program, but it has got the backing of some health regulations behind it as well. So before we take any questions, I would like to introduce the next speaker, Dr. Shin Ushiro from Japan Council for Quality. He's a well-known personality as having served on the ISQA board, and is well-known to CAHO. So I think he will need no further introduction. So Dr. Shin, please continue.
Okay, thank you very much. Okay, slide show, please. Okay. So good morning, everybody. My name is Shin Ushiro. Namaste. And today I'm going to share with you the update on quality and safety in my country that took place over past year. And the title of this session is Learning from Other Countries. That is very good for me, not only because I share my experience with you, but also because I'm going to share another country's experience with you, which is United Kingdom. So I will touch on experience of United Kingdom later on in my slide. So in place of self-introduction, I have 2 workplaces. One is University Hospital. It is called Kyushu University Hospital, where I work as a Chief Patient Safety Officer and Deputy Director of the hospital. And another workplace is the foundation in Tokyo, which runs hospital accreditation and which also runs national reporting and learning system targeting clinic, hospital, pharmacy, community pharmacy, and dental clinic as well. The one targeting dental clinic was launched last year. It was a brand new project. And we also conduct the project on QI. And at this point, I'd like to emphasize that all the project includes patient and family representatives as a committee member of steering committee, investigation committee, etc., etc. So what do you see here is the reporting and learning system, or a sort of reporting and learning system in place in my country. There are many types of reporting and learning system. On this, in this valued session, I'd like to highlight the pink one, cerebral palsy compensation investigation prevention system, because last year, Imperial College London published the annual report. It is called Global State of Patient Safety 2023. Our project on no-fault compensation targeting cerebral palsy was honorably included in the report. So I'd like to highlight the project. More than 10 years ago, nearly 20 years ago, my country suffered a shortage of obstetricians and midwives, primarily because of skyrocketing lawsuit case related to brain damage case, which took place during delivery. So the Liberal Democratic Party, which is a leading political party, launched an ad hoc committee, and they considered to launch a new novel system that provides compensation and investigation and prevention. So they published a framework that touched on compensation and bringing the conflict to early settlement and quality improvement. So the leading political party and the government and the physicians party came to our organization, which is a foundation in Tokyo, and they asked us for launching the project in close cooperation with them. And in 2009, we were successful in launching no-fault compensation system. First no-compensation system in my country that deals with cerebral palsy, in which we provide compensation. It's a monetary compensation. We provide it on no-fault basis. We do not argue if the case is negligent or not. We just provide money. And another thing we do is the investigation and prevention. And what is good and unique is that we publish investigative report that is delivered not only to professionals, childbirth facilities, but also to patient and families, so that they will know what happened to them during delivery. And what you see here is the statistics of eligible case. Here you see the steady decrease in the number of cerebral palsy. So we proudly say that the harm is reduced during the course of more than 10 years. And you may see a small notch in a certain year. In that year, we were successfully expanded the eligibility criteria. So we see a small notch. But after that, it is decreasing steadily. And you know, I said that we published investigative report and investigative report. So we have a pool of investigative report of a certain year, and we have another pool of report of a different year. So we compared two different years, and it turned out that we improved on certain procedures such as fetal heart rate monitoring is more adequate, and excess administration of uterine contracting agent, which is called oxytocin, is less often, and mechanical ventilation, neonatal resuscitation within 1 minute after birth is more common. And you may want to know about the trajectory of lawsuit case. The line chart corresponds to the lawsuit case related to OBGY. It dramatically declined. So we were really happy, not only us, but also medical professionals are really happy with the result. And through the course of operating the no-fault compensation system, at one point I happened to know that the NHS England suffers the similar problems, poor quality care in neonatal space. So what you see here is the newspaper article. You notice that some of the people carry the same report. This report is published by a midwife who is Donna Ockenden, so it's called the Donna Ockenden report. It investigated more than 1,006 cases in a certain hospital, and 201 cases were really dubious. So this issue was discussed in UK Parliament, and I was invited to the select committee of the House of Commons of UK Parliament to describe our system and to describe our achievement together with the international experts from the US, New Zealand, and Sweden. And the committee published a official report that clearly includes our data. So, as you know, I worked with the United Kingdom for a couple of years. So the report that I mentioned in the beginning of my talk includes our compensation system as one of the 9 cases that comes from global society. 5 from UK and 2 from US, 1 from my country, which is our compensation system, and 1 from New Zealand. And this is a report, but it's not just a written and printed report. It's a web-based report. So it includes my interview in a video. So maybe please visit the website of this report. And when this report was launched, there was a small reception held in the House of Lords in the UK Parliament, and I was invited. I will show you the reception in the next slide. Here you see the room of Rhodes Room of the House of Lords in UK Parliament. I was invited, and I am proudly say that Dr. Neelam Dringla of WHO, head of patient safety and quality improvement, was also invited to this reception. So I congratulate you because you have Dr. Neelam Dringla coming from your country working in WHO as a head. Okay, if you closely look at the photo, Lord Aladalzi, who is a professor of surgery of Imperial College London, worked as an MC, and he invited me. And the former Secretary of Health, Mr. Jeremy Hunt, attended, and the current Secretary of Health for Health, Victoria Atkins, also joined the meeting, the reception. And you know, there is a British media called Time. Time launched a project called the Time Health Commission in 2024. It published recommendations in February, this year, February. Recommendation 5 clearly touched on no-fault compensation system, and it is backed by Mr. Jeremy Hunt, who is an incumbent Minister of Finance in UK Parliament. So this is just a synthesis. JQ, my organization, variety of projects related to quality and safety. And the no-photo compensation system deserves to be spread globally, I believe. If it will happen in your, the cerebral palsy issue will happen in your country, I suggest that you should get prepared for it. Thank you very much. Thank you all.
Thank you, Dr. Shin, and also for keeping to time. Now we will take some questions for a few minutes. Can I ask first, Dr. Kada, how do you get clinicians involved in your accreditation system? Because often one of the laments of the clinician is, I don't have time. It is too much of paperwork. It is administrative. It's being imposed on me and so on and so forth. And I think we also had a debate here on accreditation and so on. So what is your lesson from that?
Now, the Ministry of Health actually, when they wanted to start talking about introducing quality assurance program, they actually brought in the clinicians from the beginning to be involved in the whole program. And in fact, the main person who actually brought in the whole concept of quality assurance within the Ministry of Health was actually a nephrologist. And he actually later became the Director General for Health, and he actually motivated the whole accreditation program in the whole country. So there is already a win-win situation whereby most of the clinicians are inclined to do quality improvement projects, and they willingly accept the whole quality improvement initiative within the Ministry of Health. Though we do still have some resistance, well, I think the 80-20 rule always still applies. So we do have a few very senior clinicians who actually resist the whole idea of overseeing their shoulders. But as time goes on, the Ministry of Health move it forward, and we actually were able to bring in even lecturers from the universities to convince the people, the clinicians from the private sectors to get involved into accreditation. And that's how we actually move. The trainers were actually clinicians, and they actually then buy the ideas. And now we have no issues of having clinicians going against the whole project. So we are quite happy with what we have been achieving for the last 25 years. And we just celebrated our 25th anniversary last March. Thank you very much.
Thank you. So the trick is to get clinicians involved right from the beginning if possible, and get the top involved to drive the program. I will take the question from the floor after this. Just before that, Dr. Shin, thank you for presenting your no-fault compensation.
Thank you very much.
You also have a history of, I think, having presented it to the Malaysian Minister of Health.
Yes.
And it has dragged its feet there. Now, Malaysia, from being known for a very stable government, has had 4 changes of prime ministers over the last 4 years.
Yes.
So do you think there is an element of political will in implementing such a system, which I feel is very good for the clinicians? Because otherwise they are driven out of certain fields of medicine by the high indemnity insurance that is being charged.
Okay, thank you very much. Yes, I would like to stress that the political will and political intention, strong intention, can driven the launch of the new system like no-fault compensation system, because there are many stakeholders. They are conflicting very often, but in order to launch a new system, we need to get together. So if that is the case, the political will is really, really important. But even in my country, that mechanism doesn't work very often. But in response to the severe shortage of obstetricians, severe decline in the number of obstetricians, so political will arose, and we were successful in launching the new system. So there is a voices from medical professionals and other societies to expand our no-fault compensation system to cover other clinical areas. But at present, there is no political will because it is very costly. So I agree with the idea that political intention is really important. Thank you.
Thank you. So I open the floor to one question from the floor. Please, sir. Can you give a mic, please? People? One question. Yeah. Sorry, we can't hear very well. Okay, yes.
Thank you. Thank you, Professor. You see, we people who are in the healthcare profession, who are in the accreditation bodies, we are aware of the need for a common man. My question is, what is the program accreditation bodies have to reach out to the common man that this is your right to have a quality services? My health is my right today. Common man also wants to know quality services are his or her health, her right. What is the role of accreditation body in ensuring that?
That's your question.
Common man has the right to quality. What is the role of accreditation body in meeting that common man's rights? Any program from accreditation bodies?
Okay, one of the standards that we have in our accreditation program is patients and family rights. We actually look at the needs of patients as well as family, and that is actually one standard specifically to address patients and family needs. So if we are addressing that.
How is it communicated to the common man? That is my question.
Say again?
How is it communicated to the
Now,
common man?
yes, thank you. This is an important question. In fact, in Malaysia, we have so far focused our accreditation program on the providers. We have yet to actually go to the public to share with them what we have been doing for the last 25 years. In fact, if you go down to the public by the roadside, you ask anyone, do you know what accreditation is? It's still a big question mark. So we are actually now moving forward to start educating the public that they should seek care in accredited facilities. But before we can do that, we need to bring in all our providers in, and we have done that. So now this is the next phase that we are moving forward. Thank you.
Yes, I think you have hit the nail on the head. The education of the public is so important. Awareness is important.
Awareness.
I think that in Malaysia, it is already there to some extent. Japan?
Yes, thank you very much. And if you get accredited by my organization, you can advertise the status of accreditation any place like station or the bus stop or everywhere. But in my country, advertisement of healthcare organization is strictly regulated by the government. So the accreditation status is sort of exceptional items for advertisement. So we have customers voice department section in my organization, and we get voices from customers, and we communicate with them regularly, and we describe what accreditation means, what the value of accreditation with those customers, and we publish the report, including the customer's voice on annual basis. Thank you.
Okay, I think the bottom line is, once the public is aware, they will go to accredited hospitals. The other aspect of the equation is, the healthcare providers also need to know that the various accreditation providers are equal when they are accredited by ISCO. So I think one is not superior to the other, and they should not be educating the public that I am superior to this person. A is superior to B and so on. I think that is also important for the healthcare providers. So I think with that, we conclude this very informative session on sharing lessons from 2 Asian countries. Thank you very much, and I close the session.
Yeah, thanks a lot, sir. I'll request all the stakeholders on the dais for a photo op, sir. It was interesting to hear the perspectives from both Japan as well as Malaysia. And thanks, Dr. Ravindran, sir, for moderating this chair. We move on to the next session, which is learning from the accreditation bodies. May I request the presence on the dais of for the chairperson for the session, Mr. Abraham Fenn, Chairman and President, Asia Pacific Quality Organization, APQO. He is seen today as the leading quality voice representing New Zealand. His leadership and efforts were recognized by New Zealand government, which awarded him the New Zealand Business Award in the year 2016. Joining him would be Dr. Upasana Arora, who is the Managing Director, Yashoda Super Specialty Hospital, the first awardee of ISQA Fellowship from India. She was recognized with many national and international awards for her outstanding contribution to the healthcare. I welcome both of you. Yes. And the topic is about accreditation bodies. And I think we have two very good speakers for this particular session. We have Dr. B.K. Rana, founder and CEO of Quality and Accreditation Institution, former director of NADH. His expertise are standardization in quality and accreditation. Is a name which is familiar to all of us in the audience. He would be speaking on ISO 7101 Blueprint for Quality Management in Healthcare. Welcome, sir. Would be interesting to hear on this topic. I also call upon our next eminent speaker, Kresmer Antonio Paliska, Senior Vice President and CRO, AACI. Senior Vice President and CEO, AACI America. Welcome, sir. Over to you, sir, ma'am.
Thank you. First of all, I'd like to take this opportunity and express my sincere thanks to CAHO for giving me this chance to share this very important session, session 11, and that's learning from accreditation bodies. So we have got two eminent speakers in the accreditation space. And the first speaker is Dr. B.K. Rana, founder and CEO of Quality and Accreditation Institute. Over to you, Dr. Rana.
Thank you, Mr. Chairman. Thank you very much. Good morning, everyone. Thanks, CAHO, for having me here today, this morning, and giving me this opportunity to talk to you. So good morning, everyone. Hey, good morning. Thank you for confirming your presence physically and mentally. And I'm sure after my presentation in 10 minutes or so, you will feel your presence spiritually as well. So thank you very much for joining today, this morning. But my topic is very, very difficult for me to also talk about. And I had my presentation made 2 days ago, but last night I had to make some changes after deliberation, very rich technical deliberations in yesterday's sessions. So please bear with me for the next couple of minutes. The topic given to me is about ISO 7101-2023, blueprint about this standard, which is for healthcare quality management. But before that, some disclosures. And I think as we keep hearing a lot of advertisements about issued in public interest, so I thought it's become a obligations and responsibility on us as an accreditation body to inform stakeholders about what's going on in this space. So in terms of accreditation bodies in healthcare, providing accreditation in India, they are the bodies listed over here in the slides: QAI, AACI, ACHSI, JCI, NABH, and NHSRC, National Quality Assurance Standards. And out of these,
two Indian out of three Indians, QAI, NABH, and NCLAS. Two of these, QAI and NABH, also providing accreditation overseas. So what's common in all these 6 AVs, which I presented you in full slides? And it's related to what my previous speakers talked about. All of them, all of those 6 have one or more set of standards accredited by ISCO External Evaluation Association. And second commonality among 6, except NCLAS, is they're all accredited by ISCO as an accreditation body, as an organizations. And that brings them on some common platform, some common grounds, and giving credibility to operations of accreditation programs in their own fields. And that's what Dr. Ravi mentioned as a chair in the last session. The people should recognize the importance of ISCO accreditation to the standards and organizations, to consider them as par and choose what you like. And in the field of laboratory accreditation, as you keep hearing about medical lab accreditation program, so there are 2 bodies who are part of international system, but there are 3 actually, QAI, NABL, and FDAS, but internationally, QAI, NABL are providing international acceptability and approvals through ILAC mutual recognition arrangements, and these are the common grounds which brings organizations at par. So giving a few moments on QAI, Quality and Accreditation Institute, we have 4 verticals providing different activities, including accreditation activities. And in our healthcare vertical, we provide over 15 accreditation programs based on standards developed by QAI, starting from a clinic to ambulatory care centers for hospitals and home care, ambulatory systems, transition care, inpatient rehabilitation centers, senior care, assisted living, telehealth, dialysis, IVF, emergency department, patient safety standards for WHO and stroke center accreditation program. And this is the first program I can say, if I may say, this is the first program in India which is clinician, truly clinician driven, because the assessors are neurologists, stroke experts for this program. And we developed during COVID hotel and homestay standards because COVID patients were staying in hotels, and we utilize these standards to make sure things. And some of the work in progress is in next few months, you will get new standards from QAI of emergency medical services or medical transport organization, commonly known as your ambulance services, and vision centers as a primary care, eye care facilities, and heart attack, acute myocardial infarction, special excellence program. So through these programs, we would be covering the entire patient continuum, pre-hospital, hospital, as well as post-hospital. And we are emerging as a specialist accreditation body, having so much specialized accreditation program in India. And we offer overseas as well. In our another vertical for lab accreditation, we offer lab accreditation program as per ISO 15189, which is a gold standard globally. And testing, calibration. Biobanking is a unique program which we developed first time in India based on ISO 20387, and we are the only body at the moment. We provide 3 more programs, but what we have internationally, we are the first body in India who achieved ISCO accreditation as an organization in less than 5 years. Target was 3 years, 2020 April, but COVID pushed 2 years, so we got in 2022. We have 2 sets of standards, hospital and home care standards accredited by ISCO. I'm happy to inform that QAI accreditation program for hospital, dental, eye, and imaging centers are approved by Ministry of Health for CGHS empanelment as you can to NABH for financial incentives. Internationally, we are part of ILAC, which gives us not only international acceptability, but equivalence anywhere in the world. We are approved by 2 US regulators, US EPA and Consumer Product Safety Commission. We are the only one in India having these approvals. So this is our gold seal of mark of sustained quality. We are increasing in numbers going on. We are 3 numbers short to achieve 100 mark, which we expect in next couple of months, if not years. So we are growing year over year. And just to inform, we have 49 IVF centers accredited across the country, coming from the top players in the IVF, Apollo Fertility, Art Fertility, Nova Fertility, Oasis Fertility, and so on. Home care, Protea Medical, Apollo Home Care, Max Home Care. The bigger player we're providing more than 50% home care in India. And similarly, these are the numbers, statistics touching on 97. We are spread across 10 countries, providing one or the other accreditation programs, and obviously coming up in many other countries as well. Now, coming to the topic, we talk about ISO 7101-2023. It's a new standard, first time published globally by ISO as a consensus standard for healthcare organization management, providing requirements for management systems and quality, and any range of clinic, from clinic to hospitals, any range can be covered. So ISO is an international body where the national standard bodies like BIS from India participates to develop standards. It's not something which you can take it lightly. It's a global body. So what is the framework of these standards? The standard is actually not different than what we have on QAI or any other accreditation bodies to provide accreditation or certification, but little bit differently tailored. Suits to the requirement of international community and the providers and the format of ISO. So you look at this table, it's provide you 7 chapters, you can say in your learn, but 7 clauses basically, covering the context of organization, leadership, planning, support, operations, evaluation of performance, and improvement. So if you look at, I'm sure you may not clearly reading it out, but just to give you a concept that hearing from some of the comments yesterday sessions, there's a 36-page checklist is nothing. But this 36-page checklist is not a checklist. It's prescribing the requirements for healthcare organizations for certification. And if you write it in a manner and format as we as an accreditation body write our healthcare standards, it can go beyond 100 pages. Because the writing of ISO standard is a way that you minimize the number of pages. So it's not important that you have 36 pages or 100 pages. But I think what is important is look at the content, which cover everything, starting from the organizational policies, the governance, the leadership, the service support, the human resources, any additional support you need, your management systems, your quality indicators, your patient safety requirements, everything. And the first time in this standard, I've covered about universal health coverage concepts. It also talks about sustainability, which everyone is talking about nowadays. So it's all a different part of this standard. So what I want to conclude with is a take-home message for everyone around. And I feel honored, I feel obligated as well to disseminate the information to the stakeholders like you. The content is very, very important. It's not the size of the book or booklet or the standard, but the contents matter. But it's not only the content alone will serve the purpose, it's the intent as well. I may have the best standard in the world, but that may not work when I implement it because my intention is not good. My intention is to get a certificate. If that's the intention, perhaps the content won't help, or the other way around. You have a good intention to do something good, but you don't have a good set of standards in terms of content. And therefore, it is important that content and intent both need to work together. They need to come together. And we as a provider must look at both content and intent. And most importantly, is a user empowerment. You as a healthcare provider, healthcare service providers, coming from different range of healthcare facilities, starting from clinic or a hospital, your empowerment is important. You just should decide. We should only offer the options as an accreditation body, that these are the things available. You choose what you like, what matters best to you, what makes you more comfortable in meeting content and intent of your vision. And I think that's what is critical, what we talk about accreditation, quality improvement, patient safety, A, B, C, D. But at the end of the day, a person like Dr. Venkateswar, the question very important, how we are communicating to the public, the user, about the importance of all these accreditation quality management systems. And I think this is my personal quote: quality never sleeps, but its practitioner does. We should stop blaming each other, organizations, individuals, facilities, standards, contents. But I think we should also think about whether as a quality practitioner, I'm implementing those standards, which actually makes a lot of difference for the life of people whom we are serving. Thank you very much once again giving me this opportunity to talk about some of the very quick in 10 minutes. It's a really difficult task, but I'm happy and thankful to CAHO for giving this opportunity. Thank you very much.
Thank you, Dr. Rana, for a very informative presentation. So the second speaker for this particular session is none other than Rasmir Antonio Pelisca, who needs no introduction at all. So he's the Senior Vice President and CEO of the American Accreditation Commission International. So over to you, Rasmir.
Good morning, ladies and gentlemen. It's a great honor to be here today. I'm going to have a short presentation about the ACI and how we see the accreditation today. So I want to talk something about the what's going on beyond the badge and what ACI accreditation really means for your healthcare organization, your healthcare facility. So we like to say that we are the most experienced, one of the most experienced world's accreditation body and certification services provider. Our home is in Hendersonville, North Carolina, US. We are, as you can see, globally, we are operating globally from US to Japan and everything in between that. So our mission is about ruling risks and saving lives. So our standards are founded and based on that principle, risk management, and consequently, the patient safety. Before, our vision was eliminating the world without the medical errors. And recently, we have revised that vision to mitigation of human error in healthcare, because we unfortunately have realized that the world without medical errors will never exist. That's why we are here. So the accreditation body, ACI, goes beyond just the badge on the wall. This is not what we are doing. So our standards and our principle and our accreditation program is based on the quality management and the risk management. So all the standards that we are maintaining and having in our portfolio are based on the quality management and principles, as well as the risk management. This is what our mission says. So we have three pillars where we are founding our standards: the process approach, the critical control points for these processes, and there is, as a result of that approach, is patient satisfaction, and consequently, fewer medical errors and adverse events. So the fundamental principle, the principles are measure, monitor, analyze, and improve. This is, we like to call it the PDCA cycle for the healthcare. So instead of plan, do, check, act, we call it measure, monitor, analyze, and improve. And so it's not about the standard, it's not about the certificate, it's about the measure, monitor, analyze, and improve. So this is a continual process. And I think our standards and as well as our accreditation program support that approach. So instead of, so all the surveyors, our surveyor team, are considering the importance of the process as well as the associated risk, ensuring meaningful improvement, and the meaningful improvement can be implemented in that case. So every process has and contain the risk. That risk should be taken in consideration when the accreditation program and survey itself going on. That kind of approach enables hospitals to maintain what is already good and improve areas that need enhancement. So it's not just the meaningless exercise of searching for the non-conformities. So long story short, the process is a 3-year cycle, 4 stages. So we maintain the system that has the annual surveys, annual reviews, And in that way, we are maintaining the continual improvement because we believe that one survey within 3-year cycle is just not enough. And it doesn't bring the desired results from the accreditation process. So we have a pre-assessment where it's kind of gap analysis, where we help the health organization to understand our program and our principles and our standards. And then during the initial survey and the annual surveys, we are maintaining and supporting the continual improvement on site. So this is broken somehow, so we're going to skip it. So the annual survey, we are the only accreditation body out there that providing the annual surveys. And this ensures continuous monitoring and improvement rather than waiting for 3-year cycle for the accreditation, re-accreditation review. This was the best practice from other standards, other programs like ISO 9001, and what BK mentioned before, 7101, which is the new standard now, that will require the same frequency of the periodical surveys. The special significance of the annual surveys lies in the monitoring process, especially in processes vital for the hospital's operation, and some exclusive standards such as utilization review, opioid oversight, risk management, infection control, and sterilization process. We believe at ACI that it needs to be monitored constantly because those are critical processes for each and every hospital. And to answer your question, because I heard the question today several times, why annual survey? And this is the question to ask yourself. What are the odds? Who has a greater chance for a longer and higher quality of life? Someone who goes for regular annual checkup or someone who goes every 3 years? That's a question for you. What would be the outcome? So since we are running out of time, I will also repeat, and even though BK mentioned our company as well in his presentation, we have all 3 programs accredited by ISCO. On top of that, we are also our own registrar for ISO 9001. Consequently, 7101 lays down in that scope. Once you're accredited, you're automatically certified by ISO 9001 because all the requirements, as I said at the beginning, of the ISO 9001 quality management system are incorporated in our accreditation program and or accreditation standard. On top of that, we are offering several clinical excellence programs for those already accredited, as a maternity clinical excellence program, endoscopy, and the acute stroke clinical program. And I'm going to use the last minutes for this presentation. Those are our golden seals, logos, and marks for those who achieve our accreditation and or certification program. There is another service that we are offering, and we are very proud of it. And this is something we call the web content certification, because we believe that the internet is full of harmful information that can harm the patient safety. So we have introduced the certification program we call eTrust, where the different healthcare organizations and the medical content providers are looking for our certification program in order to publish the trustful and of their websites. So this is something that we are very proud of. Nobody else does these days, such a program. Again, we do this because we believe it is connected with the patient safety, because you can harm the individual by providing lies. And we have seen that during the COVID time. Thank you so much. Thank you.
Thank you very much, Rasmir, for an excellent presentation. So we may have time now to take in one or two questions, but first I'll request Upasana to head. Thank you.
Thank you so much, Kaho, for inviting me here. I am always part of Kaho. I was with the Kaho since beginning. So anyhow, I must say that this session is very important because patient safety in India started with the NABH. So accreditation is very important. And I think in the whole world, 50 kind of accreditation are available. So I would like to ask you, Mr. Because you are from America and JCI is also there. And I think different kind of other, you have listened other speakers also. To promote accreditation, all accreditation talks about patient safety, basically, if you see. What should we do in those countries where, like in America, I know every hospital is JCI or AIC accredited. Those countries who are not 100% accredited, what should be the mechanism to implement accreditation in all hospitals? Your point of view.
Well, I think that the accreditation is like the pregnancy. You're pregnant or you're not. The same is with the accreditation. So you cannot be personally pregnant. And I think the same is applicable for the accreditation. Well, there are some countries like Brazil. I think that's a good example or may answer your question. There are 3 levels of the accreditation that they are implementing the system, which is a 3 levels. So the highest level is the accreditation. And there are other, let's say, B brand or lighter version of the standards they are promoting for those less fortunate or for the organization not being able to achieve the accreditation level. And by the way, in the US, there is no JCI, there is EJC, which is the Joint Commission, the big mama.
Thank you so much. And now Dr. B.K. Rana, who is my good friend also, you have a very vast experience of accreditation. What do you think in India, how we can, make it mandatory that all hospital has to be accredited by some or other organization?
Thank you. Thank you, Basnaji. Thank you so much. Very important and very critical questions, and I think most difficult to answer. I think world over, the accreditation has been used as a tool for improvement in voluntary space, not in a mandatory space. And for mandatory is to be the licensing requirements, what we in India call Clinical Establishment Act, establishment requirements set by the government and then adopted by the states. So I think yesterday debate also talked about that. Rather than making accreditation as a mandatory, let it be voluntary, but first set the grounds for licensing, because in my own experience, like Gyani sir must be sitting here, 2000, when I joined, 2006, when I joined NABH, and we were getting hospitals inspected for CGHS empanelment. 2006, more than 50% hospital failed in complying to the requirement of radiation safety of AERB, more than 50%. And we also face some court challenges that why we not recommending that. So I think, and that's patient safety, staff safety, biomedical waste. So I think first needs should be addressed to the masses. We talk about quality improvement, patient safety in masses, not just few hundred or thousand hospitals. When we talk about millions, globally, and lakhs in India, minimum safety standards to be in place and then built on them on accreditation for improvement. As I mentioned in the last slide, make users empowered. Let them choose what they want, what they like, bend on what they need. So I think that's my take. Though I'm in the accreditation field of 25 years,
I should be saying it should be voluntary because that's good for my business, but that's not the business. I'm not in the business of running the organization, business of patient safety. So that's my take. That should be first minimum requirement on the ground moving forward to accreditation. Thank you.
Thank you. I think we have just run out of time, so I'll take this opportunity once again to thank my co-chair, Upasana, and two of our distinguished speakers, Dr. Rana and Rasmeer, for sharing your thoughts with us. Thank you very much. With that, I conclude this particular session. Thank you. Thank you all.
Thank you very much, chairpersons as well as speakers. Please move to the front and please for a photograph. To the front of the podium towards CAHO 2024 for a photograph. So we move on to the next session, session 2012. And here we know that change your thoughts and you change your world. And this is by Norman Vincent. So here we're going to have some speakers who are going to share their experience and expertise on how they change the perspectives and the way you think and the world for safer and quality healthcare system. And for this particular session, who could be more apt than having the change person, the lead man of India, Dr. Venkatesh Tuppil. He's also the CEO and director of Foundation of Qualities India and patron of CAHO. Sir, Venkatesh, sir, please come to the dais. We do have an eminent list of speakers who are the change enablers, who are going to share their experience and expertise and what the changes they brought to the healthcare. The first is Dr. Suvru Shankar Datta, consultant, transfusion medicine, Tata Memorial Center, Kolkata. You can sit down. Okay. So he's been awarded various awards and recognition, and he's a key person for establishing molecular laboratory for blood group genotyping at Tata Memorial Hospital, Kolkata. And this is the first in India. He would be speaking on total blood safety solutions, models that work in India. The second speaker, maybe invite the second speaker as well to the stage, Dr. Arun Mawaji. He's the Director of Growth and Strategy, MedBlaze, a healthcare technology and data science venture focused on developing innovative and advanced solutions for healthcare. Dr. Mawaji. He will be speaking on driving change, the role of digital enablement in quality and patient care. The third speaker for this session would be Dr. Deepak Govil. Dr. Deepak Govil, yes, Vice Chairman of Critical Care Unit, Medanta. And he's also the Vice Chairman and Director in charge of liver transplant and hepatology critical care and gastroenterology. Gastrosurgery critical care, Medanta, Gurgaon. Dr. Deepak Goel. Yes, sir. He will be speaking on advancements in prevention and management of pressure injuries. The fourth speaker, Mr. Harish Ramachandran. He's a country segment director of Walter Kluwer. He's actually an anesthetist and intensivist by excellence, and he would be representing the Walter Kluwer. He will be speaking on catalyzing change, leveraging evidence-based medicine, enhanced patient outcomes. The fifth is Dr. Ayan Banerjee. He's from AIMS Patna. He would be an expert in molecular biology and cancer biology and endocrinology. He will share his expertise in approaching infection prevention with 3T methodology, tracking, training, and technology. Right. So thank you very much to all of you. So over to you, to Dr. Tuppil, sir, to chair the session.
we have 5 speakers to tell us about change. Change is inevitable, whether we like it or not. Every day we change, every minute we change. Cellular level we change, thinking level we change, spiritual level we change. Change is inevitable. Let us invite our first speaker. Pardon? Dr. Ayan Banerjee. Oh, they've changed. Huh? Yes, please. You are our first speaker. Name changed. Huh? Okay, that's okay. Yeah.
Subro would be the first.
Oh, 1 minute. Now it has appeared. Total blood safety solutions models that
On
work for
stage,
India.
we invite Dr. Subro Datta. Yeah.
So good morning, everyone, and apology for this inconvenience. So we are hearing about this patient safety since morning. So let's talk about some kind of a blood safety. So I'm going to speak on total blood safety solution model that work for India. So if you look at the importance of the blood safety, in every 3 seconds, blood transfusions are needed around the world. So most of these blood transfusions are for patients who are having trauma or patients undergoing cardiac surgery or transplant surgery or transplantation like bone marrow transplantation or patients having kind of a complicated pregnancy cases. Now, prevalence of transfusion transmitted infection is a challenge in low to middle income countries like us. According to the government of India, we have to screen all the bloods for 5 organisms like HIV, hepatitis B, HCV, malaria, and syphilis. But it is a challenge in kind of a less regulated settings because of unavailability of proper sensitive and specific testing platforms. Now, coming to the Indian perspective, we have around more than 3,000 blood bank registered under DGHS and Drug Control General of India. And last year, we collected around 12 million units. So why blood safety is a challenge in India? Mostly because of the seroprevalence rate. So if you look at the hepatitis B seroprevalence rate, HCV and HIV, you can see that hepatitis B seroprevalence rate in India is quite high. So it's 0.87%. Though it is less than 1%, if you multiply this less than 1% with our population, which is approximately 1.4 billion. So around 12 million people with hepatitis B infections are there in the population. And most of these people are asymptomatic, having chronic hepatitis B carrier state or occult hepatitis B infection. So apart from the high prevalence of this hepatitis B, low voluntary donation and lack of standardization of the screening-based techniques are also responsible for compromised blood safety in India. Now, we all know this era is an era of components. So you collect 1 unit of blood and divide it into 3 units. So RBC can be used for managing the anemia patients. FFP like plasma can be used to manage the coagulopathies, and platelets we all know can be used in cancer patient, in dengue surge and other conditions. So if you miss one transmission transmitted infection, you are putting 3 lives at risk. So it is very important to ensure the blood safety. So how do you prevent transmission transmitted infection and provide the safe blood to the patient? So according to the government guideline, the serology-based tests like ELISA or the chemiluminescence are practiced in the most of the blood centers, but you have to have an additional layer of safety. What is the additional layer of safety? That is the molecular-based assay, like nucleic acid testing. So if you combine both of them, then you can provide the total safe blood to the patient. So what actually NAT does? It actually reduces the window period. We all know the window period is from the entry of the microorganism in the body to the serological detection by means of the antibody identification. So NAT can reduce the window period of hepatitis B from 60 days to 1.34 days. In hepatitis HIV, it's from 21 days to 2.93 days. So it can reduce significantly the window period of this infection. So what is the net yield? So if you are testing all the bloods and these bloods are coming negative in your traditional testing platform and you are putting an additional layer of safety and these bloods are coming as reactive, that is a net yield. So these are some of the published data from Odisha, UP, Punjab, and Kolkata also. So in Kolkata, one center study got 25 NAT yield. So actually they saved 75 recipient of being transmitted infection. So the 4 key advantages of the NAT, of course, it can reduce the window period. It can enhance the sensitivity and specificity of the testing. It can have a longer consequences, like it can have a impact on the patient service. And of course, some of the mutant variants which are not detected in the serological means can be detected at molecular level. So how we can implement this NAT testing in India? So WHO recommends hub and spoke model or centralized approach for NAT testing in India. So Odisha was the first state to implement this particular model in the public healthcare providers. So they actually included all the government blood centers in this model. So how this model works actually? This is suppose you are having 10 to 15 blood centers in a region. You collect the blood, transport the blood to a single testing facility. They are testing, uploading the results to the IT companies or any software, and then the mother blood centers can read the results, and based on the results, they can release the unit. So the whole process will take only 48 hours from the time of the collection to the issue of the blood for transfusion. So actually, this particular model is also adapted for the PPP partnerships, and actually the target is to have all blood banks to have NAT PCR by 2025. So the same model was taken by the Karnataka government and the UP government. So coming to the health economical benefit, of course, it can reduces the cost by adopting the hub and spoke model. It can improve the patient outcome, as we discussed. It can have an impact on quality of life. And of course, this whole model is a cost effective if we think about the long-term outcomes. So this actually the last month, the International Blood Transfusion Services reviewed all the nucleic acid testing facilities across the globe to standardize what is the actually pool size to test the NAT. So they come around 6 pool NAT testing. You are accumulating 6 samples and testing it in a platform. Then if the samples are positive, then you test the individual unit. This is a cost effective. This particular method is a cost effective manner. So you can improve your testing facility by incorporating this testing facility. So in TMC Kolkata, we adopted 6 pool strategy, and till March 24, we actually screened more than 12,000 donors, and we already got 8 NAT reactive. So 7 of them got hepatitis B virus detected and 1 was hepatitis C. So we actually saved 24 recipients to have a transmitted infection till date. Thank you.
Thank you, doctor, for covering well in time. If there are any queries or any questions, we can have 1 or 2. Okay. You need it. Can you provide the mic?
I'm just saying while doing a pool testing, why not 8?
At the end, we can have
Yeah, anytime. I'm just saying you ask.
a lot of echoing, we can't hear.
I'm saying, can the number of in the pool, you said that 6.
So you are talking about the pool size.
Yes.
So yes, the International Blood Transfusion Committee has reviewed the pool size and they got that 6 pool strategy is the ideal one. Why? Because if you increase the pool size, it actually dilutes the sample. And if the viral threshold or the viral load in the sample is low, if you're diluting the samples more, then you could miss the particular pool. So 6 pool strategy is the ideal for the low to middle income countries. You can reduce the pool also to increase the specificity, but it can enhance the cost factor.
Thank you very much.
Thanks.
I think I recommend for any interaction at tea time or lunchtime you can have, because lot of echoing. I am not able to even hear what you are talking, Dr. Vijay. There's some echoing going on. Maybe problem with my hearing because of old age, or I don't know whether the technology. Anyway, thank you very much.
Thank you.
You are saying. I invite Dr. Arun Mawaji. Driving change, the role of digital enablement in quality and patient care. We cannot go away with digital change, we have.
So good afternoon, one and all. So we're just talking about technology and some of its pain points, but I'm sure I'm going to talk something that will probably give some positive insights into the technology. My topic today is driving change, the role of digital enablement in quality and patient care. So in simple terms, digital enablement is nothing but empowering healthcare organizations and healthcare professionals through digital technologies, aiming at improving patient outcomes, improving efficiency, as well as improved patient engagement. We see we already been using and aware and well known of various technologies. It can be the digital front-end technologies, like patient registration portal that the patient can book appointments, order medicines. It can be a hospital information system, an EMR, learning management systems. So most of the hospitals will be using one or the other form of digital technologies in our day-to-day activities, and we would have realized how impactful it would be to have these technologies. So what is driving change? So at least from a macro perspective and an India perspective, so we need to understand that we are a very large populous country with close to about 1.2, 1.3 billion population. And for a population like us, if you look at even the estimated projection of healthcare spending that the government of India is projecting, close to about 6% of GDP will be spent on healthcare, and about 69% of people will be insured. So even these benchmarks are very inadequate, or I can say we're still not progressing well when it comes to healthcare spending as well as the population getting covered under insurance. Second thing, which is very alarming, is the year-on-year medical inflation, which is much more than the general inflation. So that means to say that the cost of treatment is increasing every year, and this burden is passed on to the patients. And with the kind of insurance coverage, which is very much inadequate, much of the people are facing financial crisis because of this increasing cost. And this cost is not only on the patient, but even on the healthcare providers, because the cost at which they need to provide treatment is also increasing. So this is a worrisome trend that we need to realize. And apart from that, we are a country with high chronic disease burden. Close to about 50% of population has one or the other form of non-communicable diseases. It can be cardiac or diabetics, any form of chronic health issues. So it puts a lot of stress on the healthcare facilities and also invariably increasing the cost of care. We are an under-resourced country, so the number of bed to population, the number of doctors to population is quite less. So all these things, can be extremely challenging, especially if you look at the quality of care. What I mean is like access to care, the availability of doctors and healthcare facilities, the cost and quality at which these cares are given, it becomes severely compromised. And there is no other way that we have to go digital in case if you have to solve much of these problems. The silver lining has been, of course, the general usage of digital technologies has been an upstream, especially post-COVID. We are so used to using apps. This has been facilitated by the number of smartphones and the internet connectivity India is currently having. Close to about 50% or 60% of the population have one or the other form of internet connections, and they're using smartphones for be it entertainment or be it for e-commerce. So, as a sort of byproduct of this usage, the healthcare consumption in form of app-based usage, app-based service for healthcare has also increased. So if you look at the data, shows a preference for online consultations, which was picked up somewhere during the COVID, is still sustaining. So close to about 50% of population in metro prefer teleconsultations even now. And this is a trend even in Tier 2, Tier 3 cities as well. Second thing is that during COVID, most of us became aware or got used to usage of digital health technologies like the COVID app or the teleconsultation platform. So this trend continues to remain because a lot of startups came up in this space providing teleconsultations, online delivery of medicine. So and by the consumer behavior of convenience. By offering convenience, much of these apps are still holding on to the customers, and this has actually improved digital usage of healthcare technologies. We must really congratulate Government of India for pushing digital technology to a great extent, especially with platforms like Ayushman Bharat Digital Health Mission, the National Health Authority platform, which is giving a lot of impetus to healthcare institutions to onboard. So, creating digital IDs for patients, registering healthcare professionals, registering healthcare facilities. All this enablement by the government itself has sort of been a boon for digital technologies companies as well. The notable features having, the longitudinal patient health records, which will have a big impact in terms of the quality of care because, most of the time we lose medical records, which is very precious document. And having a, ABA ID and having a sort of a digital repository of information, which is interoperable, any healthcare facility can view our records. So, the quality of patient care is going to increase. And apart from that, we're going to have a ONDC like platform, that is Open Telemedicine and E-Pharmacy Network, which will again going to bring down the cost of care, especially from the OPD point of view. If you look at even India's telemedicine service, eSanjeevani has already crossed over 14 crores consultations in the year 2023. So this is all sort of a testimony to the fact that the impetus from the government as well as the usage from the consumers towards digital technologies has been growing, and this is where we need to grow. Another interesting concept is integrated digital adoption. Again, these are all post-COVID inventions when large healthcare institutions realize that they have been threatened by startups, especially coming to the teleconsultation, remote monitoring, other things. They felt that, okay, they need to have something of their own. And this is where, world over, the integrated platform delivery of digital technologies came in. And one example that is very close home is the Apollo Care. So if you look at it, they have launched Apollo Pro Health that looks at screening of diseases, especially the chronic diseases. They have virtual consultations, online medicine delivery. So everything, virtually everything they have covered. So these are examples where traditional healthcare players, the large traditional healthcare players, they're offering everything from pre-hospitalization to hospitalization, including the insurance coverage. Narayana has come up with its own health insurance. So if you look at it, even the traditional healthcare providers are moving towards digital enablement. So this is where the world is going to be. And what is the value of digital technology and data for health and healthcare? So Deloitte did a study and then they interviewed a lot of CXO level people. They wanted to ask what would be the most important criteria for them to choose digital transformation. And the top two reasons were to improve patient satisfaction and engagement and to improve the quality of care and patient outcomes. And this is what my topic today is as well. So how is technology helping improve patient experience, quality, and patient care? These are some statistics, which I'll not go in detail, but we need to understand that digital enablement has really brought in improvement in revenue, has brought in cost savings, and improved staff satisfaction as well as patient satisfaction. All these are published studies that I'm quoting here. And on a macro perspective, if you look at it, this is where, in Kenya, they have deployed large-scale digital enablement, and they have done studies to, and this is a World Bank study, and they realized that close to about 7 to 11% reduction of cost at the country level can be achieved by use of digital tools, especially teleconsultation, remote monitoring, quality management systems. So that brings me to the last, this is also what I do and which I'm very passionate about. We all talk about quality, but we need to realize this, having the traditional approach to quality management does not serve any purpose. And quality management information system is not just an accreditation management tool or an event reporting tool. It goes beyond that. So, just like how HI has evolved, quality management information systems have also evolved, and they provide an entire gamut of, services, right from how do you credential your staff to having a integrated learning management system, an event reporting system, and advanced data analytics that helps the stakeholders give you real-time information in terms of how safe is your organization. And we also have tools that empower patients to report safety. So ultimately, event reporting or incident reporting often gets missed because the people who have to report, they don't have immediate access to reporting, or patients don't report on their own. We are not sufficiently empowered our patients. So these are the tools, modern tools that are available, which sufficiently empowers the patient to engage with the care providers, report any incident that happens on real-time basis. These are some of the results that we have seen in our own installations. We have close to about 500 installations in 15 different countries. And wherever organizations have permitted us to, look at the outcomes, we have seen there is a considerable decrease in the paperwork. That means the administrative burden has been taken off to a great extent so that they can focus more on quality improvement efforts. We have seen an improvement in net patient scores, improvement in the patient engagements and other things. So this is where technology comes in, and technology tools like quality management and information systems comes in. And to conclude, as I said, improving healthcare will get more difficult and it will not be easier. So it is better that we adopt one or the other form of technology to improve our care delivery. So with this, I conclude my talk. And I thank CAHO for the opportunity given today. Thank you so much.
Thank you, Dr. Arun. Thank you for covering the entire spectrum of digital health. For lack of time, we'll move on to the next speaker. I know there will be a lot of inquisitiveness and questions. Okay, please. Is it Dr. Deepak? Okay.
Respected Chairman, Dr. Venkatesh sir, and Dr. Agarwal sir, President CAHO. First of all, I would like to thank CAHO for inviting me here and giving me this opportunity where I can share some of my thoughts. So today I'm going to talk on the advances in the prevention and management of pressure injury. As we all know, if the pressure injury happens, then the treatment is quite costly. So first and foremost thing is the prevention of any injury. As we all know that the incidence of pressure ulcers is everywhere in any hospital setting, but it is mostly seen in the critical care units, in the elderly old age units, and the operating theater. And of course, it is there in pediatric care as well. So we need to have a better prevention model. What is happening, new research and better understanding has given light that our traditional prevention methods and products which are available are not enough. So we need more evidence-based practices. We need more data, more evidence to come to know what is currently happening and how we can prevent these. If you know about the bundle, what we call a bundle is a different elements which if we follow them in a combined way, they will give results. So each element of the bundle may not give you desired result, but if we follow them as a bundle, they will give result. So implementing as a pressure injury prevention bundle is going to help us in preventing these type of injuries. These are some example of the pressure injury prevention bundles. One is I have taken from the NHS from UK, which is having 5 elements in this. One is the surface, make sure that your patient have the right surface and right support. Then skin inspection, early inspection of the skin and early identification of the pressure ulcer or the area where they are having the risk of developing pressure ulcers can be done. Then keep your patients moving so that they don't develop pressure ulcers. Then look and manage the incontinence and the moisture, because these two things can cause pressure ulcers. And then finally maintain the nutritional status and the proper hydration of these patients to avoid development of the ulcer. So this is one of the easiest bundle having 5 elements. Other bundles are having much more elements, and sometimes it becomes difficult for the caregiver to implement those bundles. How we can identify at-risk patient and risk assessment tools? So there are more than 21 tools which are available for identification in the pressure ulcer. But you can understand so much of the literature cannot be done at the bedside. So most commonly we use the Braden score, Norton score, and Waterloo scale. So these 3 are the most common. Every score has got their own limitation. Either they are too lengthy or difficult to implement. So we have to choose them wisely so that our staff can implement them and assess patient accordingly. Turning and repositioning devices are going to play a major role in the prevention of pressure ulcers. And repositioning is there to reduce the duration and the magnitude of the pressure over vulnerable area of the body. So as a prevention strategy, we can change the position accordingly. Maybe around 30-degree position change can be done 2 hourly basis, from side laying position, right side, left side, and on back. If we do this type of changing, so the pressure on the pressure points is going to change and circulation will be maintained. There are different methods for turning and repositioning devices. One of this type of devices is there, which I have shown in this picture. You can see here the device is there. And these devices can be used conveniently, and their efficiency is there in 2 hourly changing of the position, and they require less of the nursing care and the staff. So this another device which was around for a 35-degree tilt device, which is being used in Western world. And there is some study was done in their American 3 ICUs. And what they have said that hospital-acquired pressure ulcers have gone down to 81%, 73%, and 85%. So huge reduction in the hospital-acquired pressure ulcers by using these type of devices. And these type of devices saves much on the manpower front also. So if we combine their benefits, the manpower cost is reduced by around 80% in these devices. There are many more devices for turning, repositioning. These type of mechanical devices are being used mainly for the obese patients, where it becomes very difficult to move these patients from bed to the chair and from the bed back to the bed. What is the role of prophylactic dressing in the prevention of pressure injury? Is there any role? So yes, of course, the prophylactic dressing plays a very important role. This is a misconception in our mind that we apply the dressing when there is already an ulcer is developed. But if we apply these dressings prophylactically, they can help in the redistribute the pressure from one area to the overall skin. They reduce the shear and friction forces, and they manage the temperature and the moisture of that area. So they have got big role in the prevention of the pressure injury as well. So different type of prophylactic dressings are available in the market. Essentially, the silicone foam dressings are there. They have got deep defense technology. They optimally balance the strength and flexibility, and soft silicone border is easy to remove without any pain or any peel. there is one thing called finite element modulation in the wound care. So what are these finite elements? So there are certain finite elements which are the computer simulation program that studies the impact of multiple forces in material stress and deformation. So it is basically a computer simulation program by which we can assess the pressure, we can simulate where the pressure points will be there so that we can take care appropriately before they develop. So that's how in finite element modeling, first we do a complete 3D modeling of the pelvis or the area where the maximal pressure is going to be there. And then we do a accurate 3D modeling of the dressing structure, and design is completed based on the data from the material testing so that it fits accordingly and easily. And then in a simulation of the realistic level of the pressure and the shear on a soft mattress is conducted to understand the impact of these extrinsic factors on the tissue deformities. So in the finite element results, they have done multiple testing, and what they have found that 5-layer silicone foam dressing has maximal impact on the high stress area. It reduces the stress on the impact around 90 to 100%, whereas the routine dressings which are available, they reduce 0 to 10% of the impact only on the high stress. So 5-layer foam is a proven prophylactic dressing. There are few RCTs available, which shows that there is a more than 80% reduction in the pressure ulcers by using these 5-layer foam. So 5-layer foam, they have got great potential to save the cost as well, because if we are able to prevent the pressure ulcer, it is having a cost effective to hospital and the patient as well. These are the special population that have been specifically considered for this type of prophylactic dressing. Those who are critically ill individuals, individuals with a spinal cord injury, individuals receiving palliative care, individuals with obesity, neonates and children, individuals in community aged care and rehabilitation setting, individuals in the operating room, and individuals who are in transiting from one center to another center by way of ambulances, maybe stretcher and all those stuff. So emerging research in the pressure injury, there is we all know that artificial intelligence is coming into every aspect of the healthcare, and the pressure ulcer prevention is not left behind. So there are many artificial intelligence based solutions which are coming into the market, which can assess the pressure ulcer areas, which can assess the microcirculation and the tissue damage at the pressure area. And few apps are also available and few instruments are also available in the market. Thank you very much. I hope I have completed in the time.
Yeah, very much in time. Thank you, Dr. Deepak. Please be there. You see, he has created problem to me now. What is that problem? From morning 8 o'clock, 9 o'clock, I'm sitting till evening 5 o'clock on the chair. No, this is a concern because most of us are about 70 years. Tell us something how to take care of ourselves from pressure injuries.
So just change the
This is something when my health is my right. I need good suggestion to us also.
Rightly said, sir. So the suggestion is please change your posture after 2 hours. Just take a stand up, just have a small round and come back again. Thank you very much.
Thank you very much. Thank you. Our next speaker is Dr. Harish Ramchandra. Welcome.
Hope you can hear me. Good morning, everybody. First of all, thanks, CAHO, to give me an opportunity to talk about this interesting topic, which I feel. The topic here, which we have, is leveraging evidence-based medicine to enhance patient outcomes. I think it's clearly a topic of a lot of interest, converging with various other topics which were talked earlier. If I have to go and start off, let's probably start putting it down as a challenge. And I think this challenge is not new. There are people who have spoken about it. I think in India, as of 2020, and I'm taking a little older data, unfortunately, where it's like saying 7.35, we have 7.35 doctors to a 10,000 as a population ratio. Now, when I start looking at it, this is one of the elements on which I know the government of India has worked over the several years. It's improving, it's increasing at a significant pace. That's correct. Now, along with it, what also comes is another major challenge is having newly qualified doctors who have the ability to diagnose and treat patients with three aspects, which is quickly, accurately, and confidently. I think if I take that topic and start saying, and I take that part of the challenge and start figuring it out, how can we overcome this challenge and provide access to quality care and which is cost efficient, because we are in India and we have to look at it. I think this is where the element of evidence-based medicine starts playing a role. And one of the quotes which I have kept there, where somebody talked about digital health also. And when you look at digital health, I think that's the element which will start flipping this eminence-based medicine towards evidence-based medicine. And when I start taking this aspect and try to put it in a picture which is easier for us to understand, this is probably a journey which all of us have seen. Which we are referring to here would be a clinical decision support of an evidence-based medicine at every step of the care journey. When a patient starts off getting admitted into the emergency department and starts presenting himself with one of the problems or a couple of problems, and then starts moving over finally back to home, I think you see a triangle, red triangle in every one of them. These red triangles basically represent a place of a key decision. Along with the key decision also comes a risk point, because that's an area where it can create a harm or a safety issue or a quality issue towards the care delivery, what we are trying to deliver. So that's the place where that evidence-based medicines can play a major role. So, and that's where a CDSS tool, which is there with an evidence-based medicine, can start adding value. So given its importance, what I would say is, when I start looking at it, what is an evidence-based tool? It's basically to be at a point of care, because that's a place where you're treating and managing the patient. And it needs to be from across the spectrum, starting from a diagnosis up to a treatment decision. And it basically synthesizes the latest evidence in a quick form, because the amount of research work and the challenges which we have in healthcare today, and particularly post-COVID, I think it clearly shows the amount of papers which are getting published and the amount of evidence which are there. So it needs to synthetically get those evidence and start putting it through and give it as a quick recommendation. It should be easy to access. It can't be in a very complicated way, which means it can be on a computer, on a mobile phone, of course on EMR also. Then this should also have a consistent, not only for one person, which we always say that's clinicians, but the entire critical care team, or the care team, I would say, which is doctors, nurses, technicians, everybody, and the spectrum of doctors too, starting from a consultant to a. Last but not least, it should also engage the patient in their own care, which is through patient education and various others. This is what is called a composite CDSS, which would sit there. Now, that's correct to know what a CDSS is, but why is it valuable if you start putting it through? These are some of the references in the data which you're seeing. These are all white papers which have been published. The volume of literature today is very complex. Every clinician would have at least 15 to 20 questions per day. Now, if I start flipping that, and if you don't have an evidence-based medicine clinical decision support, what could happen probably would be there is 60% of the questions can go unanswered. And that's a classic means of 5 to 8 different points where it could have probably impacted safety or the quality of what is being delivered to a patient. So answering these questions is what is critical. Now, this is also fine. These are all numbers which are input. We'll probably take some of those examples which are there globals and which are trying to see how this has impacted. The picture what you're seeing in front of you is a study which was done, a research study which was done. It's a peer-published study, which is done at the Tokyo Jodo Hospital. It's purely made into two separate sets of people. One control group used a clinical decision support tool, up to date, and the other one did not use it. And if you look at the results which came out, it was a startling difference where it reduced the diagnostic error rate from 24% to 2%. Clearly, it means it has added value at the point of care in the way it is done. This is one way of looking at it. Now, we flipped another story, and yesterday when I was hearing somebody talking about the quality of healthcare being delivered in Singapore General Hospital. This is a research which was done at the Singapore National University Hospital, where the bedside use of UpToDate had led to changes of patient care decision 1 out of 3 times. You're seeing 37% there, which is basically 1 out of every 3 decisions which were made had a change and an impact of that delivered onto the safety and quality of patient. So clearly it adds value at the patient treatment or even a diagnosis, which you saw earlier. Furthermore, I think an element which we'll start looking at it. This is another interesting study which was done. It's a Harvard study. This was done over a period of 3 years. And we all know US is another system of healthcare is much more evolved. And this was done across 1,000 hospitals. And what came out of that study was 11,500 lives were saved by the usage of UpToDate or a CDSS tool. Now, it also impacted on another thing, which is on the ALOS, because I think when I've been here for the yesterday and today when I'm hearing it, we talk of what ways ROI and everything else is being talked. It saved 372,000 days, which is a significant number of days, and manpower and doctors burnout, everything can be do that. So that's critically saying that there are a lot of evidence which is already there for the evidence-based medicine to be getting used on a day-to-day practice. Now, the most important thing which probably people would start thinking is, there are some myths which are there. If I have to start dispelling this myth, you don't need an EMR to adopt to any evidence-based medicine. Because like what I said earlier, the best evidence-based medicine will bring in a CDSS tool, would be available for you at the point of care in a simple mobile app or any kind of other form. Other common myth which we have heard is you need a big infrastructure, which is not true. You don't need. You just need an external IP. And today, I think one of my esteemed colleagues was talking, saying how IT has moved, the networks which have improved. The last one, which also comes to my mind, which always I hear, is a clinical decision support system tool should start trying to give me alerts. The first thing which we'll have to say is it's a decision support tool. It is not a decision maker tool, and which means to say it will never be a replacement for a clinician. So the other element which I said, it's for the entire care team and not just for doctors. I think one of the other elements which we keep getting is it's all about the technology. CDSS means it's all about the technology which runs. The only flip of it is that it's a technology, but based on evidence-based medicine. If the content behind it is not an evidence-based one, then it will start struggling. So if I have to say all this is what was CDSS, evidence-based medicine, how it has been successful. I think the bigger question which will start running in all our minds is, this is fine for probably the outside world. I've just put some elements for you for what we are in India, because I think it's important to know where we are in India also. Today, there are more than, over the last 5 years, if I have to say, there is a significant jump in the number of hospitals, clinicians adopting to that evidence-based practice. We have more than 400 plus institutions. And if you look at the 3 different elements which we are trying to talk, 91% of those, and because these are feedbacks which come through the usage and people giving us the feedback through the campaigns which are there in it, 91% of them agree that it helped and improved the quality of care being provided to patients. And if you start looking at it, the trust and the element which start coming in, which means to say, for that topic which I started saying, evidence-based medicine starts forming a place where it starts improving on the patient care, patient quality, patient safety. But at the last, which I will have to probably leave it as a thought, is 400 in India is just a tip of the iceberg. I think there's a big iceberg which is left to be unearthed. So I think that's the place where I will leave it with a question for everybody. Thank you once again for giving me the opportunity to speak about this subject. Thank you.
Thank you for joining other speakers in maintaining time. Congratulations to you. Thank you, Harish. You spoke my heart today. 1952, a book was released, textbook of biochemistry by one of the famous international authors called Devlin. In the foreword, he had written, today's biochemistry is tomorrow's medicine. He gave importance to laboratory. Today, you have highlighted importance of diagnostics, importance of evidence-based medicine, without which clinicians may not even look at the patient. But how much of it is relevant is the question. Many of my friends send me the report they got when they go to hospital. I get confused. So many tests are carried out. Is it required? How much of evidence-based medicine is appropriate in a country like ours? Otherwise, it will become only commercial.
Absolutely.
Can you please make a comment?
If I have to answer, sir, I think this is one common question which we keep hearing from people saying, how much and how long, how much do we use an evidence-based CDSS tool? The answer is that there are two parts to this answer. One is a CDSS tool is like a backup. It is sitting there. It is only when you are in that dilemma. So there are two elements which it brings in. Number one, it reinforces your decision or it changes your decision as a clinician. This is the biggest element what it brings in. And when we say statistically how often do people use or what is the benchmark, there's no ideal benchmark, but what we do believe is if a clinician is even looking at it 2 to 3 times in a week, I'm just saying 2 to 3 times in a week, it is considered to be at a pinnacle. In fact, most of the usage, if you look at it, sir, is not in front of the patient. You don't need to open that in front of a patient when you're doing it. You're sitting in a car, you're going back, you're thinking about a case, what was done. Was that my best to be done, or is there some other evidence which you can report? Second could be also in cases like many other countries where it is used even to justify medico-legal problems, because you could take different aspects to treat or manage that patient, but out of your best interest, you have taken what you think is right, and the evidence is supporting it, which will clearly say that that is the right direction to go. I probably am trying to answer that much.
Thank you. Because please don't go in for 900 rupees, 400 tests. It will create more of a psychological problem tomorrow. If some value somewhere this side or that side, you will not be able to sleep. Today, the new announcements, 400 rupees, 80 tests, 900 rupees. Isn't it, Dr. Ravi? Number of tests, now a package. I don't think that should be taken into consideration. Maybe our artificial intelligence will collate and coordinate and tell us what is required, what is not required. Thank you.
Thank you, sir.
Anybody wants to have any clarification? We still have time. Yeah, please.
So we are using this up to date in our institution, and I find not only for the patient care, it's good tool to teach juniors and fellows as well, because otherwise they get confused how to read, where to read. It becomes like a bedside teaching tool. It's a wonderful tool. So you see a patient, then ask them to just open their mobiles and look at what's there. So they can come to know systematically 1, 2, 3, 4 how to manage that patient.
Thank you, Dr. Deepak. Okay, we have our next speaker, Dr. Ayan. Tracking, training, and technology.
Good afternoon, Chairman, sir. And good afternoon, this August audience. Thanks, CAHO, for inviting me to speak upon this very important topic, approaching infection prevention with 3T methodology, tracking, training, and technology. So all of us know this fancy structure that is visible on screen, and which has wreaked havoc throughout the world. And it has emphasized how infection prevention is very much essential for all hospitals. So this is COVID-19. So before COVID-19 and post-COVID-19, the scenario is different. So CDC defines hospital-acquired infection as a localized or systemic condition resulting from an adverse reaction to the presence of an infectious agent or its toxins without any evidence of its being present or in incubation at the time of admission. An infection is attributed as HAI if date of event occurs on or after 3rd calendar day of admission, where the day of admission is counted as day 1. So why it is so important? Globally, 7% of patients is in developed countries and 10% in developing countries will acquire at least one HAI on an average. And that is about 10% of these affected patients in European region. CDC estimates that on a given day, 1 in every 31 hospital patients has an HAI.
And 70% of this infection could be prevented if the healthcare workers followed recommended protocols, including hand hygiene and infection control. So what is the scenario in India? This is very 4 to 5 years old newspaper clipping in Times of India. The report published that globally the accepted rate of HIV is up to 8%, but in India, unfortunately, it is about 18%, which is quite high. And out of this, 1.5 to 5% are ventilator-associated pneumonia, 7 to 10% is due to septicemia, 25% is due to SSI, and 40% is COTI. So in Indian scenario, the International Nosocomial Infection Control Consortium reports that healthcare associated infection prevalence in India is approximately 9 infections per 1,000 in ICU patients days. And the rate can be varying between 4.4 to 83%, which is quite variable depending on the hospital care, healthcare setup where the patient is admitted. A study tracking HAI in tertiary care public hospital found that mean length of hospital stay due to HAI who had matched with controls by age and gender was 11.96 days more than non-HAI patients, which is quite high. Effective infection prevention control requires constant action at all levels of the health system, from policymakers to facility managers, health workers, hygiene specialists, and those who access health services. So who are susceptible to nosocomial infection? There may be some intrinsic patient factors like age, comorbidities, immunity, etc. Extrinsic factor contributing to healthcare associated infections are high-risk medical devices like central line, intubation, operative procedures, and other therapeutic and environmental pressures like antibiotic resistance and ambient environmental factors. So this is a chain of infection. If the host is susceptible to infection, the infection microbes gets in, and if they become the reservoir of the infection, portal of exit, it goes to the mode of infection like fecal-oral or other routes, it enters into next host. So to prevent the spread of infection, we have to break one of the links in this chain. So what are the commonly faced healthcare associated infection in hospital? Mainly CLABSI, that is central line associated bloodstream infection, COTI, ventilator associated events, surgical site infection, clostridial difficulty, that is GI sepsis, and hemorrhage. So how to prevent? To prevent this hospital healthcare associated infection, we should approach in bundle care. Already Dr. Govil has explained what is bundle approach is. It is basically comprising of 3 to 5 evidence-based elements with strong clinical agreement. Each of the components must be followed during the insertion or maintenance of the device. Compliance to the bundle care is, I think, is it over? It's from the previous. It is probably from the previous speaker. So compliance to the bundle care is calculated as all or none way. That is, failure to compliance to any of the components leads to the non-compliance of the whole bundle. So we have bundle care for central line to prevent CLABSI. Maintenance bundle for ventilator care to prevent VAP, SSI bundle. And also we should not forget about, we should not think about only central line, also peripherally inserted venous catheters are creating problem for infection. So PBC associated bloodstream infection or sepsis is a far more serious adverse event of catheterization. More likely mechanism of PBC BSI is the colonization of a vascular catheter tract due to biofilm. So we should prevent using three-way stopcocks. Rather, we should use this slit mechanism to prevent portal of entry of infection. So this is the latest guideline to prevent CLAPC in hospital from IDSA. So greatest challenge in infection control today's in healthcare is healthcare associated infection as well as emergence of MDRO like MRSA, ESBS, and VRE. So achieving optimum hand hygiene is required using personal protective equipments, safe handling and disposal of clinical waste and body fluids, achieving and maintaining a clean clinical environment, good communication with other healthcare workers, patients, and visitors, and training and education is required. So how to track infection prevention? The primary aim of surveillance program is to assess the rate of infections and endemic likelihood. Hospitals usually target surveillance of HAI in areas where the highest rate of infection is. Mostly it is ICU, hematology or oncology unit and surgery units. So monitoring and auditing of the critical data, antibiotic stewardship, reporting and isolation of diseases when reported, and training and education of the staffs required. So surveillance may be active or passive, patient-based or laboratory-based, prospective or retrospective, targeted or targeted toward the hospital. So infection control training, post-COVID, we usually target first training the trainers. So extensive training program for selected team of nursing champions is required. Ward-wise training for nurses or clinician, hand-holding session for doctors for newer technology upgradation is required. So what are newer technologies that are coming into infection control? There are electronic hand hygiene monitoring devices offer hospitals a large data sets for hand hygiene compliance among healthcare workers. Though WHO does not recommend it, there are advent of antimicrobial textiles, also ultraviolet C devices for irradiation and infecting larger instruments in hospital setup, and optimization of EMRs for infection prevention practices. So the decisions, it helps in decision support as a decision support tool and predictive modeling by machine learning to the clinician, adding extra benefit for the patient. So what are the challenges we are facing in India in infection prevention? There are lack of regulation or poor compliance to the regulation, non-existent national level policy for infection prevention control, limitations of resources and insufficient funding by the government, inadequate infrastructure and management of healthcare setting, surveillance of infection prevention and control practices, lack training staffs and understanding of definitions, lack of bundle approach to cause lessening of HAI, lack of data collection formats and collective methods of data collection and definition, deficient information management system for data collection, analysis, and dissemination. Also, indiscriminate antimicrobial use causing national level problem due to lack of antibiotic policy and codification, poor implementation of guidelines, lack of first-line antimicrobial like benzene, penicillin, etc. to uses of second-line more potent antimicrobials, risking emergence of MDROs, and deficient antimicrobial drug usage data also quite causing problem. Shortage of trained healthcare staff and inappropriate biomedical waste disposal also is there in India. So if you are aware of the infection, then you should take care of it. This should be the motto, and we should be vigilant enough and detect infection at the earliest. So diagnostic stewardship is more important than antibiotic stewardship. So we should diagnose the infection first and go accordingly. Thank you.
Thank you for once again reinforcing my health is my right. Today is the day to remember that. Thank you very much, Doctor. If there are any questions, we can have one or two questions. We have. Therefore, after listening to Doctor, I know there are a lot of opportunities in this country, a lot of challenges also, as far as this subject is concerned. Solution is technology. I think you said alternative technology like UV and many other things.
But not only technology will help, sir. We should be conscious enough to diagnose it early and
adopting a good hand hygiene practice and training the staffs. These are also required.
Thank you. Thank you.
Thank you.
Thank you very much, Chairperson and the speakers. Please come into the front of the stage for a photograph. So let's move to the next session.
So this is the launch time. There was a question by Dr. Venkatesh sir that is there a solution for this? Yes, we have a solution. From the era of culturing in the plates to automated systems, now the world is moving to next generation sequencing platforms, and we are all looking for a syndromic approach in infectious diseases. So to answer this, I think there is a solution from Amneal team. I invite the Amneal team to join us on the stage, please, Ms. Chaitra. I also request Dr. Lalu Joseph and Dr. Vijay Agarwal sir to please join us for the launch of this platform. Dr. Vijay sir, please.
I just need to say something.
I request Ms. Chaitra to share a few words about this platform. I invite Dr. Sagadullah sir to please join us on the stage to launch this platform.
Very good afternoon to all of you. Thank you, Dr. Malti. A very, very big thank you to CAHO for providing us with this platform to introduce our organization among such an eminent audience. My name is Chaitra. I head medical affairs for Amneal. Amneal, with its legacy of providing good quality and affordable medicines in the US for the last 20 years, is now foraying into India with some innovative products and cutting-edge technology. I'm very proud to announce the launch of DXN1, which is a next-generation sequencing-based testing for identification of pathogens and their sensitivity and resistance patterns on all sterile sample types. DXN1 is a platform for providing unique pangenomic solutions like BACTFAST, FungiFast, VirFast, and digital ABST. BACTFAST essentially is the pan-bacterial genome analysis, which identifies over 22,000 species and subspecies of bacteria. Given a positive result, there is a reflex digital antibiotic sensitivity testing that can be done. FungiFast is a pan-fungal genome analysis, which identifies over 6,000 species of fungi. Especially post-COVID, emergence of new fungi is a very big challenge in a lot of ICUs. And VirFast is a pan-viral genome analysis, which identifies over 9,000 types of DNA and RNA-based viruses. We would like to show you a short video on the launch of this DXN1. So please.
What should I do? Just to announce shortly? Or I have to press? Press where? Yes. All right. Okay, with all your permission, I'm very delighted to launch this platform, which is helpful for the infection control. And infection control is already been highlighted, is one of the major problems of our country. And we need to do a lot more. With all your permission and prayers, it's a good platform. I'm launching it.
Welcome to the new world of innovation and possibilities. Welcome to Amneal. Founded in 2002, our journey began with a simple vision to make essential medicines more accessible and affordable to all.
Time has come to leverage the assets of Amneal outside of US. It will help us give access to patients who are in need.
Welcome to the new era in infectious diagnostics testing. Introducing Amneal Genomics. The growing threat of antimicrobial resistance has put a huge burden on hospitals and clinicians. There is a need for a next-generation diagnostic tool that offers cutting-edge technology with comprehensive pathogen coverage, enabling clinicians with a conclusive report. Introducing DXN1, the 3C approach to diagnosis. That's cutting-edge. Comprehensive, with pangenomic panels like BACTFAST, which identifies more than 22,000 bacterial species. digital ADST, which can identify associated drug resistance pattern, Verfast, which identifies over 9,000 DNA and RNA viruses, and FungiFast, which identifies over 6,000 fungal species, including the recently evolved one. Conclusive. Join us as we continue to evolve and make healthy possible for millions around the world. Visit any scientific booths for more information.
Thank you, Amnil team. So far we were learning from other countries. It's time to learn for the globe. What are we doing for the Mother Earth? So it's time for a panel discussion from our experts on sustainability in healthcare. To moderate this session, I invite Dr. Lalu Joseph, who needs no introduction. She's the Secretary General of CAHO and Associate GS and Quality Manager from CMC Vellore. Ma'am, can you please join us on the stage? The next moderator for this session is Mr. Supratik Sarkar, who is a unit head from BM Birla Heart Research Center, Kolkata. Sir, we invite you to join us on the dais, please. So we have the key expert panelist on sustainability in healthcare systems. The first panelist, I would like to invite Mr. Anil Johari, who's a former CEO from the National Accreditation Board for Certification Bodies. Please join us on this dais, please. Can we have a big round of applause for inviting them, ladies and gentlemen? The next panelist is Dr. Karan Thakur, who is a group lead for sustainability and ESG and the Vice President of Public Affairs from Apollo Hospitals Group. May I invite Mrs. Kirti D'Souza, who is a sustainability professional and Managing Director for Lifegiver Professional Services, to join us, please. We have another key sustainability expert with us, Mr. Vinod Kumar, who is a consultant of Facility Management System from Rajagiri Hospitals, Aluva. So thank you for joining us. I now hand over the session to the moderators.
Good afternoon. Thank you, Kaho, for taking up the session. Thank you for giving us the opportunity to discuss this very important topic for us. I was just discussing with Dr. Joseph as well as others earlier, what does sustainability mean to all of us? And what do we even think about it? So, in a sense that it is all about meeting our present requirements without impacting or negatively impacting the ability of the next generation to meet theirs. Now, that incorporates a lot of sense, meaning in a sense that what are we trying to do for ourselves? In this entire journey, if we look back and say that, what have we been able to do? I think our journey in sustainability is quite cyclic. Why do I say cyclic? It's in a manner that, I think my grandparents were far more sustainable than me. And I think my next generation is again far more sustainable than us. So therefore, we have hope and we do not want to lose hope there for sure. So that's the more global version of it. So what in a healthcare scenario are we doing? What are we trying to do? We have an eminent panel of guests here who we hope to discuss the next 25, 30 minutes in a sense. What do we want to do in a sense of where are we? What sort of state are we in? Is it some sort of a journey that we're taking? Is it a rich man's fad? Is it something that's a tick box? Is it something that we believe in? Is it something that would definitely lead for some change? So let's hear from our distinguished panelists. We look forward to having a very intelligent discussion. Thank you so much.
Thank you so much. And I think it is the commitment to sustainability that made us launch this sustainability forum yesterday. And we are indeed very proud that we have eminent panelists here with us, and they've been working very closely on how, as healthcare fraternity, we can address the issue of sustainability. So let's make it a little interactive. And I think I'll pose some questions to you. And if you are able to keep it short, we are running, I think, about half an hour late. So our session is also slightly cut. So Karan, you are a very eminent person in sustainability. You've contributed a lot to the field in healthcare. So I think you should give us an overview. And what do you think is the significance of sustainability in healthcare? Why should it matter to us at all? Your thoughts?
Thank you. Thank you for having me, and thank you for having this panel discussion. There are two aspects to this question that one must consider within healthcare. One is the impact of climate change on human health. And that is definite, and it is playing out in different geographies, but a significant pattern has been set into place. Let's take, for example, the city that I come from, New Delhi, where we had dengue fever as something which one witnessed post monsoons. Last year in Delhi, the biggest outbreak of dengue was in December. And this is a clear shift in pattern of the disease that we are seeing because of change in vector ecology. And now, why does that happen? Last year's Lancet study points out that the suitability of these carriers has increased over time because of climate change. In effect, we are going to be feeling the effects of climate change on human health more and more directly. And that's why we say that for all of us within healthcare, we should state very clearly that the climate crisis is a health crisis first and foremost before it being anything else. And how does that impact me as a practitioner or a healthcare manager? Well, take that example of dengue and what was prevalent in Delhi during the winter months is flu and other sorts of infections, viral infections that one sees. On top of that, we are now going to have dengue fever continuing its run post monsoon. In effect, for hospital managers, administrators, doctors, and nurses, we will now have to look at this challenge more granularly in terms of how climate change, its impact on human health, will impact my operations as a whole. Point two is that not only does climate impact human health, the healthcare sector itself is contributing towards the climate crisis. If healthcare were a country, we would be the fifth largest emitter as a nation. 2.7 gigatons of carbon dioxide is released into the atmosphere through health activities. Let me just bring this home. A single CABG surgery that is done in any hospital, any good hospital in India, is equivalent to the carbon emissions of a small petrol car traveling 250 kilometers. That's one CABG procedure. Multiply that by all the procedures that are happening in one hospital and then within the healthcare system. So we have to become mindful of the fact that we may be doing social good by providing healthcare, but at the same time, we are also contributing towards what I consider the biggest challenge that we faced as humanity.
So can we do anything about that at all? I understand one CABG procedure. And do we have data? Do we have data to say, okay, a surgical procedure is emitting so much? Let us say other activities that we undertake, for example, our laundry, our CSSD, or the supply chain. Do we have data at all in our country? Are we banking on some developed world data?
Exactly. That is the biggest challenge that presents itself, which is how do we now start quantifying the problem in your hospital, in your ward, or in your service that you may be offering. And there we find it being very uneven. Some hospitals have taken the leadership and have established good emissions frameworks and know exactly what their consumption patterns look like, whereas others do not. The second problem is that there is no taxonomy on how do we actually define consumption patterns or even come to more granular level definitions of what emissions means within healthcare. So like for many other aspects, we are relying on Western data, which is not appropriate. In fact, one of the foundational reasons for starting CAPS was this, that we will generate data from within the Indian healthcare system in different settings, whether they're large hospitals, small, medium hospitals, across the provider networks, and come and arrive at, good decision points for us to take action on. Is action possible? Yes, on three aspects: adaptation, mitigation, and resilience. Adaptation basically means now that there is already some change which has become permanent in terms of climate change, whether it's heat waves, air pollution, so on and so forth, how do we adapt as a hospital or as a health network or as a health system? That is going to become important. If you're in a flood-prone region, how are you going to make sure that you climate-proof yourself? The other is mitigation, which is what we discussed. When we set bench lines for ourselves in terms of what our consumption looks like, we will then start reducing them through a whole host of interventions, whether solarization, et cetera, et cetera. And third is resilience building, which means if we were to get a climatic event which were to knock us off the grid or knock us off the utility supply, do I have the passive survivability to go on and continue to provide services? Because unlike any other function, you can shut down an office block, you can shut down schools, you can shut down anything else. When a climate crisis erupts in a climatic event, people are going to be coming towards you, not away from you. So these three are key action areas where every hospital, every health system now needs to start thinking seriously about.
Thank you. And I think I have one more question taking from what you said. We started the initiative on CAPS. So formally, it's not launched as it, but can you briefly tell us what we are going to be doing with CAPS through the Sustainability Forum?
Yes, the first is capacity building. This is not going to happen. Just go back 2 decades back when the quality journey in Indian healthcare started. It was not a single person's job. It's not as if you hire a chief quality officer or designate somebody, you're going to have a quality organization. Similarly, for sustainability and for climate and health impacts, it needs all of the organization approach. So we are going to do capacity building. We've already launched the first 12-week masterclass, which we ran from October to January of last year, spilling over into this year. And we will do more of these. And this resource is actually now available on the CAHO website for you to really understand the nuts and bolts of what sustainability looks like and how you can take action. The other is we are going to be doing baselining studies, which is what we have initiated to see how hospitals vary in terms of their patterns and therefore what are the interventions that a bouquet of interventions that we can offer. Third is to put out some research papers, white papers through the good examples that are already there within health systems. We saw a few examples of that in the Health Environmental Awards that we had announced this year. Very good case studies that came out, which are applicable despite your size or maturity as an organization. So it is not just about capital outlays, it is also about practices which you can change and make a difference towards. And lastly, this is about collaborations. We are looking at collaborations, whether they are academic, research, scientific, or project-based, and also from technology and from other interventions, which we can then deploy in a project phase or in a proof of concept stage, and then scale those up across the health system. That's broadly what we're intending to do with CAPS.
Dr. Karan, thank you so much. Interesting, and running a cardiac hospital, the CABG reference immediately drives home. So thank you so much. Mr. Jared, then you, in a sense, drawing from your great vast experience, we just wanted to check with you as to why are standards in sustainability necessary? Why would you say that you need to have a set of them?
Thank you. Thanks, CAHO, for inviting me to this panel. Before I answer your question, I would like to share a feel-good story, which has standard, which has sustainability, and which has healthcare all together. When COVID was at peak, the principal scientific advisor to Government of India, he set up a subcommittee on quality, where I was also included as a member. And among the issues that we were given, one I remember was related to ventilators, the other was related to PPE. And the issue given to us was that there was a huge generation of PPE waste. And Secretary Health had written to Secretary Environment seeking solution to this issue of huge amount of waste which was there. So we had a small group of people who discussed this issue. And one of the solutions that was given was about multi-use PPEs. Typically, I think doctors would know that they're wedded to single-use, wear and throw it away. So multi-use also is a problem of mindset more than anything else. So when this was suggested, one enterprising manufacturer came up and he said that if multi-use PPEs are to be successful, the washing and laundering would have to be controlled. So he came up that we need a standard for laundry, hospital laundry. And he said he's prepared some draft, but he needs a laundry expert. So I reached out to Dr. Gyani, and he suggested a laundry expert, and the two of them sat down and produced a draft. And then I said, why don't we send this draft to BIS and ask them to create a national standard of it, which BIS accepted, and that has been going through the BIS process of creating a standard. Since BIS was a bit slow, I also requested AMTZ, I think I can see Jana sitting there, that can you take this draft and produce a certifiable standard in a lesser time than BIS would do? And fortunately, Dr. Sharma was kind enough to accept that, and we went ahead and set up a program for certifying hospital laundries, which is today 1 year old. Today 1 year. On the other hand, I was also working with the Indian International Finance Corporation on a global PP project. And I organized a roundtable with our international partners, PSI and ASTM in US. And in that, I was able to get the chair of ISO TC 304, is Healthcare Management Technical Committee, of which 7101, Dr. Anand Put. And she was present in that. I think Dr. Joseph was also present in that. And she said she wants this subject to be proposed to ISO, and she wants to make a standard in ISO. And finally, with some pushing to BIS, that subject has actually gone to ISO with a draft. And hopefully in future, BIS would lead, and India would lead creation of a standard on multi-use PPs, laundering of multi-use PPs. So there you have a standard coming in, international standard coming in, you have sustainability, and you have healthcare together, everything together. So standard, when I joined BIS, which is the national standards body in 1980, fresh out of IIT, we were given some induction training and told standards are solution to recurring problems. If an issue is there, which recurs again and again, you standardize it in a document. But to me, a standard has another value in India, especially in India. Given the huge challenge we face in every sector, whether it's agriculture, where we have smallholder farmers, whether it is industry, where we have huge amount of small and micro industry, whether it's healthcare, where there's a large number of small hospitals, single doctor-driven nursing homes, etc. And the challenge is that while Apollo can afford Karan and Karan can advise them on sustainability on a full-time basis, these people cannot afford resources of that nature. And they need guidance. They want to go on this journey, be it quality, be it sustainability, be it safety. They want to go on that journey, but they do not know how to go about it. And therefore, to me, one of the biggest values of standards India has been that it gives guidance to those who are not so equipped. I mean, if we can put down, say, 10 best good sustainability practices in healthcare and put it in a document form, now everybody knows that, okay, if I have to do something, these are the 10 things I need to do. And you can start. BIS has, CAHO has given a draft to BIS. I'm aware of that, and I'm pushing that in BIS to hopefully we'll create something through this initiative of CAHO, maybe go to ISO TC 304 and produce another standard on healthcare for small, especially for small, sustainability in small. So I think that's what I would think standard is necessary. In general, yes, but particularly in Indian context, given this huge amount of smaller people who need guidance.
Well, just a small follow-up. How do you think the healthcare organizations reporting these, since reporting the sustainability, can become more transparent, can become more credible? What would you suggest and recommend? That's the full standard in a sense of how to follow, and how do you become more credible and recognizable in a sense that your standards are more.
See, typically ISO has a neutrality principle. Any standard should be open to self-implementation and self-declaration. I implement a standard, I make a declaration myself that I comply with the standard. It should be open to a second-party evaluation. If I'm a user, I'm buying from you, I can evaluate you against that standard and say, yes, you comply, I am willing to buy. Or it should be open to a third party. Call it certification, call it accreditation. In sustainability, it's called validation. Globally, the term used is verification. So third-party verification seems to be an answer to produce credible statement. And it's being called verification because typically certification or accreditation, as you know, is against defined standards. A verification of claims. So here in sustainability, usually it will be, you will claim your emissions, you will claim this is a fact, and then there should be verification. So that's a system that will, I guess, that is developing all over the world. How that system would be supervised, I have been in this game for several years, and I am also aware of the pitfalls of this third-party system. So let's see how it pans out in as far as sustainability is concerned. But yes, we would have verifiers, independent verifiers who would do that. Who those are independent verifiers and what is the oversight is still a.
Thank you. So I think it's a social responsibility and self-regulation is the key. And the guidance.
Self-declaration is actually a formal way of demonstration of compliance. And in European regulation, you'll be surprised, just for the information of all of you, all those products that you will see with CE mark, 70% of those products under regulation, they are CE mark is a regulatory mark. 70% of those products are based on self-declaration in the European law. So self-declaration also is a very effective or very not effective, popular means of demonstrating.
Absolutely. Thank you. Thank you, sir. And we have with us our own expert, the field of building management, Mr. Vinod, and we really owe a lot to him for initiating the Engineers Forum. And now we have the Sustainability Forum, which is an offshoot of the Engineers Forum. So Vinod, the built environment, all of us talk about it, plays a huge role in healthcare sustainability. Majority of our emissions are generated from our own infrastructure, right? Yeah. So what steps have hospitals taken? You visited several hospitals. What do you think have been the steps that they have taken? And what steps should they take? So there are two questions. What have they taken? And what do you think they should take? Not very expensive solutions.
Thank you, Dr. Lallu. The built environment, as you see, is one system that utilizes so much of energy. And without utilizing the energy, you cannot do your day-to-day activities. The systems need it also. What I have seen in the various hospitals is that of late, they have started becoming sustainable. They have taken measures, be it a new building construction or be it existing construction, existing building. The new building construction, what they have employed is they have followed ECBC guidelines. They have employed the right architects. They have employed the right MEP engineers to work on the design aspect, which incorporates all the green and sustainable aspects of that. So that's the first step to that. As far as we are concerned, healthcare needs a lot of energy. So we cannot say we can be carbon neutral or net zero quickly as possible, but the steps are in the right direction. So most of the hospitals have taken up following the regulations in terms of the design aspects, in terms of the equipment selection. Because unless you do that in that manner, you will not definitely achieve the right product. That's one part of it. The second part with the existing hospitals, they have a long way to go because these are all, many of them are 30, 40 years old. Some of them are 10 years old. So the options they have started is utilizing energy audits, looking forward to agencies who will help them to identify the right products when it comes to condemnation and replacement. So high energy equipments, high energy systems are better processors are set in place so that they come down in their energy utilizations. So they are in the right direction, but I think it's a long way to go.
Absolutely. So do you see, let's move on to the climate change part of it. You know, many of our hospitals have problems with Chennai floods. We saw what happened. And of course, the heat wave is another major challenge in the North India and now in the South as well. So what are the mitigation strategies and, the risk management framework that we can work around? Because that's also another major area that we have to look at when we talk about sustainability. So what, in your opinion, are we doing? Are we there? Can we give some guidance to the hospitals?
I think you've touched upon risk assessment as part of how critical the system is, and can we accept failures when we have bigger aspects like floods and temperature increase due to climate change. Generally, what has to be done is the hospitals should look at working on where they are in terms of the current facility and what happens if there is a disaster. So they need to work on the hazard vulnerability analysis part of it to see what are the hazards that are lurking around the hospital in the vicinity, in the geography they are in, and then work on the aspects of what are the existing measures we have and what are the corrective actions they need to do. So the mitigation measures have to start straight away because I have been part of Chennai floods 2016. I've been part of Kochi floods 2018. Now again, Chennai is back to the same thing. And this year, the summer in Cochin has actually gone much higher. Temperatures are 2 to 3 degrees more than what it was the last year, almost 40 degrees. So the challenge is quite impending and things have to mitigation measures have to be taken very quickly. So these are the tools that the hospitals have to work in, not wait for the disaster to come and then start looking at what has to be done. Yeah, thank you.
Mr. Vinod, then closer home in the sense that in Calcutta we had faced two major cyclonic storms, and suddenly within the next 2 hours, the entire city did not know as to what to do them and what happened. Healthcare organizations are extremely vulnerable as to what sort of a response mechanism. And as you mentioned, the mitigation was extremely important for us. And what learnings did you have from them to bring it up? So thank you. Thank you so much for bringing that for us. Ms. Kirti, thank you. And we'll draw from your greater experience. We wanted to learn and obviously hear you tell us about how hospitals across the world measured success, sustainability. Now, what are the measures that we see worldwide? Worldwide, what are the measures that we have?
Thank you very much. First of all, I would like to congratulate CAHO for giving importance to the matter called sustainability, a very, very important task that has been taken to create capacity building through masterclass, and launch of this sustainability forum is going to take one step towards the practices that we have to lay on ground. So if you look at the international scenario in other sectors and in healthcare sector, we see that people are definitely urging to put their commitment forward, to put their vision forward, and not only around climate crisis, which is a huge cry today, but also into the space of the 3 pillars of sustainability: the environmental pillar, the economic pillar, and also we have the social pillar. So healthcare associating themselves to these 3 pillars, understanding that sustainability is not only environmental or green practices, but it is much beyond the green practices to governance practices, and also to see the social responsibility within the hospital and around the hospital. So world over, people are aligning themselves to measure their commitment of sustainability in these 3 pillars. That's the first thing that I would like to put across. The second thing is, if you look at the other sectors, there are several goals that they have been coming up with. So internationally and nationally, for example, the goal of net zero. That is really driving. For example, in India, we have taken up the goal of 2070. But if you look at oil and gas sector in India, they have committed to 2047 to become net zero. Now, the meaning of net zero is that it is not their physical boundary within which they will become carbon neutral, but they will carry the value chain along with them, the upstream and the downstream together, and then become carbon neutral, which is a great example for healthcare, because in healthcare, what we have is not only the scope 1 and 2, the portion of this is hardly 17% to 20%. So the big responsibility in healthcare is 70 to 80% of the footprint, the carbon footprint, is in the value chain, the upstream and the downstream. The upstream is our supply chain, and the downstream is totally our customer, associates, a daycare center, pharma centers, etc. So we have a huge responsibility to come with innovative ideas. We want people to come up with innovative ideas. How can we tackle this big responsibility of 80% footprint to be tackled? So that is where I think global, the scenario is the same. India, the scenario is the same. And we as CAHO have great opportunity here and responsibility to lead with examples.
Thank you, ma'am. Just wanted to again sense what the outcomes in matrix would you say that healthcare organizations, hospitals should start reporting or can report towards the sustained journey in a sense that gives us some sort of an understanding as to where we stand.
So definitely when we measure, then we know where we are. So when we look at the sustainability performance measurement, most of the organizations like Apollo and many other corporate organizations have tried to collate the data in accordance with the Global Reporting Initiative, what we call as GRI, which gives the indicators of performance. And that's meant common across for all sectors today. But there is a commitment from GRI. There will be a sector-specific GRI index that will be brought for healthcare also. In the 20 list, the healthcare also is appearing. So it gives a plethora of indicators, whether it is environment or social or economy. In all the three pillars, that plethora of indicators. For example, if we pick up environment, we have indicators for specific energy consumption, specific water consumption, specific material consumption, specific waste. Now, what is the meaning of this specific? What is my waste generation per bed generated? How much is my energy per bed consumed? So this is the kind of metrics that each hospital needs to come up with. And that helps us understand where we are, do the baselining, and then have the benchmarking done with respect to the various categories of hospital, what Dr. Karan was mentioning. So we have a big task ahead in terms of measuring, putting that baselining and benchmarking exercise, and seeing what we really can achieve as a community.
Thank you. So we call Kirti the sustainability lady in Kaho. She's very passionate about what she does, and Karan is equally passionate about the work that he does. So congratulations to the team for starting this initiative, the Kaho Forum on Sustainability. And we are very sure it is in safe hands because it's the passion that drives this organization. And when people with that passion come forward to take it forward, we know it is in safe hands. So congratulations to all of you, Vinod, Anil sir, for taking this and encouraging. So I would like to invite people who are interested in sustainability to get connected to Karan and Kirti and join us in this journey, because we need to understand that we do not inherit the earth from our ancestors. We borrow it from our children. We have a lot of responsibility towards what we do. So it's time that we join hands and make things that we can do to make our journey sustainable. Thank you all, and thank you panelists and my co-moderator for this wonderful session. Thank you.
Thank you very much to the team for just sticking to the time and for the wonderful deliberations and experience sharing that we had. To the front of the podium for a group picture, please. So moving on to the last pre-lunch session. This is a very quick session, which is on learning from other industries. This session would be chaired by Dr. Anuradha Pichumani. I don't think she needs any introduction at all. She is the Executive Director of Sri Ranga Hospitals, Chengalpettu, Tamil Nadu, and she's also the chairperson for the Quality Professionals of CAHO. The speaker for this session is Mr. Sharad Mishra, Director, Health and Care India, Sodexo India Service Private Limited. Yes. So Mr. Sharad Mishra is the Director, Health and Care India, Sodexo India Services Private Limited. So over to Dr. Anuradha Pichumani and Mr. Sharad Mishra.
Hello. Good morning to you all. And as you all have been here since morning, so we have been hearing about sharing practices across organizations from accreditation bodies across the globe. And So CAHO has been a leader in sharing best practices, and it is a mission that we start learning from each other. And that's how we are in this session. And as you all are in healthcare, it's a most complex and challenging industry, as we all know. And to improve patient safety and quality, we need to start having innovative ideas, have some disruptive innovation so that we are able to take patient safety and quality in a bigger way. And so we have various industries from where we can learn on. Even CAHO had a previous program with Mumbai Dabbawala, where we were able to understand the process efficiency. Similarly, we have various checklists. We have the health reliable organizations where we are learning to reduce the errors. So now as we are moving in forward, we have with us the director of Sodexo, Mr. Sharad Mishra. So I understand that Sodexo has been working on a global platform, including healthcare services and various other industries. I invite you to
Thank you so much. Thank you.
Hello, everyone. Good afternoon. Last session, so bear with me for maybe a couple of minutes. So I represent an organization which, through its services, has impacted quality of life of millions abroad and many individuals and organizations in India. Very quickly, I would want to maybe share with you two very clear use cases where through our services, we have solved some major problems and also impacted quality of life of hospitals and all its stakeholders. Now, I think everybody would agree with me that a hospital is as good as the clinician mavericks which are associated to the hospital. But then we also understand that where does a doctor place his trust most, right? And for us, it is the medical equipment. We realize that, the doctor's diagnosis, the line of treatment, everything would depend on how precise, how well maintained the medical equipment is to his disposal. For that very reason, we understood that this industry of medical equipment maintenance is quite fragmented in India. And we came up with a very comprehensive plan almost 6 years back, which was one of its kind in the country. And very proud and honored to say that we started from this very city of Kolkata, where we had a major contract of managing almost 70% of state's medical equipment from the government sector. So what we did was, we realized that the challenges in medical equipment maintenance are, many and it is quite fragmented. It could be availability of spares, lack of standardization, high cost, and sometimes the visibility is not there with the hospital management, the admin team. Imagine if the hospital C-level at the click of a button in the morning gets to know what is my uptime of a hospital, how many equipments are working, not working. If not working, then what is the reason behind? And for every equipment, you get to have a good database at the click of a button. That level of transparency is what we wanted to bring to this very, very grave problem. So this is the value proposition. A typical hospital does this crisscross. And whereas in the right side, if you see with our HTM, we call it Healthcare Technology Management, we become the focal point, the interface. So hospital need not use its very important bandwidth in maintaining service contracts of OEMs or service providers. Hospital staff should primarily be responsible and bothered about giving a good patient care, spending as much time as possible with the patients. And that's what we strongly propagate. So this program is a comprehensive program where we have covered everything digitally. So the entire maintenance happens on a web platform through mobile as well, where everything from the time you do the asset mapping, tagging, their PMS, the calibration schedule, everything is available to the hospital at a click of a button. And not only that, we understood that this problem has to be addressed from all corners. We have our own NABL accredited lab right here in Kolkata. We have the highest level of safety and quality accreditations, whether it is ISO 13485 or all other AERB for that matter, is something which we already have with us. A world-class spare depot, which ensures that the right quality of spares are provided at the right time. That's very, very important. Logistics plays a very important role in this overall maintenance program. Maybe next 2 minutes, I want to touch upon another use case is how well we have defined patient dining or patient meals. Now, we have all heard, said, maybe most of us agree also, that the patient's meal in a hospital has to be seen as part of his recovery. Now, in the pandemic time, we realized that most of us were worried as to, the Indian way of cooking, the right usage of spices, the right procurement. All of that was on top of our mind. And we thought it's responsible for a credible company like us to come with a program. What we did was we signed an MOU with All India Institute of Ayurveda in Delhi. And we tried to understand that what goes in making that very food as part of the therapy, what goes into getting the right nutrients from that food. So since the institution is expert in that, we learned that the slow cooking method, right usage of spices, avoiding saturated fats, all of that went into this whole program. And now with our own team of chefs, we have developed recipes which promote health, well-being, and obviously the overall vision is that from illness, we as partners to the hospital reach to a level of wellness, but that's not the end. We want to reach a level where we can say that we practice well-being. Well-being is our ancient way of living. In all our ancient books and scriptures, you see that health is something which has to be enjoyed. Health is something which has to be promoted. And through all the preventive measures, we can achieve that. Thank you so much.
Thank you, Mr. Sharath, for keeping it very short and telling us how to be a partner of choice from illness, wellness, and then moving on to well-being. And I think we need to adapt from all industries, and specifically he has told us about Arogyam also. And you need to adapt and acquire knowledge and adopt it to your own context. And that's how you improve your patient safety and quality. Thank you so much.
Thank you.
So this way for a photograph, okay, with ma'am. Yeah. Thank you very much to the chairperson and the speaker for keeping up with the time. It's a pre-lunch, but a well-conducted session, please. Sir? I have the yes. So now we have a very beautiful video for the World Health Day by Dozy. And after this video, we will break for lunch. And please note, we will join back here at sharp at 2 p.m. To start the post-lunch session and the valedictory. So over to the console for the video, please. Kunal? The video. The console is there. Video. 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 Post lunch at 1:55. Okay. All right. All right. I think we will look at the video post lunch. We break now for lunch. There's some technical glitch in downloading the video.